Nice to be with everybody this morning. I'd like to take the opportunity to introduce you to the Penn team. Like Abby said, I'm Casey Halpern. I'm joined today by a great team of movement experts, experts in tremor, experts in medical management of tremor. We all know that occasionally medications aren't enough, and so procedures become necessary, and we'll spend some time today discussing what those procedures are, when they're appropriate, how we do them. We have some of the country's foremost experts in these procedures here at Penn. Dr. Cajigas, my partner, will be sharing his robust experience on deep brain stimulation. Very proud of another newest member of our team, Li Ming Q, who will be sharing her experience with focus ultrasound. And remember, these procedures follow medical management. And so Dr. Feldman, one of our fabulous Penn neurologists, will be sharing her experience using medications to treat tremor first. This will follow with a great team approach, because even medicines and procedures aren't enough. Nurses like Gabby, as well as my nurse practitioner, Denise Miller, play a pivotal role in taking care of these patients before and after surgery and preparing you for procedures, helping guide when we use procedures instead of medications. Sometimes we use combination approaches. We have to ready your family to help take care of you. So this is a team effort. We have a fabulous partner with physical therapy expertise who will also be speaking with you today, and really thrilled to also be able to welcome some patient participants who can share with you their experiences. I'll take a moment just to shed some light on my personal experience taking care of patients with tremor. And these are patients mostly with essential tremor, but also patients with Parkinson's who have tremor. And sometimes we see tremor after brain injury or stroke. And so you can think about tackling tremor holistically with some of the strategies we'll share with you today. But most typically, or most commonly, these are patients with essential tremor. When I started my career, I met with a support group leader. This was when I was in California, and she told me she felt that essential tremor was the forgotten disease. Even though it's 10 times more common than Parkinson's, everybody knows what Parkinson's is. And she asked me why that was, and I assume this was because of the great work of Michael J. Fox, sort of a public figure, celebrity who's raised over $1 billion to help do research and develop new diagnostics and treatments for Parkinson's disease, as well as improve awareness. But because of that effort, whenever you see tremor, you assume you have Parkinson's. But the truth is, it's more likely essential tremor, 10 to 1. People that have essential tremor, that problem is 10 times more common than Parkinson's disease, at least. And it's one of the most common neurologic conditions for patients over the age of 70. So we think it's really important at Penn to put our best foot forward with a comprehensive team, from neurology to neurosurgery, invasive and non-invasive procedures, nursing, social workers, physical therapists. We also have memory experts who help take care of these patients. So a real comprehensive approach that you really can only get in this region at Penn. So thrilled to be with you. Hopefully the agenda presents information that is new to you. Please feel free to chime in, ask questions during the Q&A, and I'll leave it to Gabby to introduce the following speaker.
Okay, just to mention before we get started with the presentations, we are going to leave time at the end for any questions. So if you do have any questions, please type them in the chat box down at the bottom there, and then we will go over them. So we are going to get started with medical management for essential tremor with Dr. Jessica Feldman. Dr. Feldman graduated from Tulane University with a degree in biology and later graduated from Tulane School of Medicine. She completed her internship and neurology residency at the University of Pennsylvania. Dr. Feldman was given the Zaritsky Award for Outstanding Research by a Resident. We also established the program for neurology residents to rotate at a hospital in Botswana during the HIV/AIDS pandemic of the early 2000s. Dr. Feldman was in private practice in Bucks County from 2006 until 2021, when she joined the University of Pennsylvania. In 2023, she was awarded the Golden Apple Teaching Award for the Drexel Medical School and was then awarded the A.B. Baker National Teaching Award from the American Academy of Neurology. Dr. Feldman is a general neurologist with an interest in movement disorders, and she has a large practice of patients with brain stimulators. Dr. Feldman does both medical management as well as adjustment of stimulator devices. He currently has offices in Southampton and Sellersville, Pennsylvania, as part of the Penn Medicine physician specialty practices.
Thank you very much. Good morning. Welcome. I hope this is educational, informational for you all. So I'm going to talk a little bit about medical management. And as you'll see, there's actually not a lot of great medical choices for essential tremor. It's fairly limited, which is why deep brain stimulation has become such a critical part of management for a lot of my patients. But we always start with medical management. So I'm going to start with a background there, and I'm going to talk a little bit just about essential tremor in general. So it's a neurology talk, so you can't get away from the basic science portion. So a little bit about genetics of essential tremor. So over 50% of cases are familial. However, the majority of the genes that are associated with essential tremor, we actually do not know what they are. We do know it's genetic, primarily because of the incidence in monozygous, so those are identical twins. So identical twins are twins where there's one egg that's been fertilized, one embryo that then splits. So those twins have identical genetic makeup. They have identical DNA essentially, unlike fraternal twins where there were actually two eggs that were fertilized, and they're closer to siblings than they are traditional twins if you think about it from a genetic standpoint. But the incidence is about 90% in identical twins. There's a couple genes that have been identified, ETM1, which is on chromosome 3, ETM2 on chromosome 2. But as I mentioned before, those are in smaller portions. One was in a group of Icelandic families, the other in a group of Czech families. The majority of the genes we still do not know. We do know that the majority of the time when it's genetic, it's autosomal dominant. So what that means is each parent has two chromosomes, and then you'll get one chromosome from each parent. And if you inherit the chromosome that has the essential tremor gene on it, then you will express that gene. Unlike a recessive where you have to have both of your chromosomes have to have that gene on it. In a dominant, you will express it. And there are varying ways that you'll express it. In some cases, it'll be what's called anticipation. So younger generations will express the gene at a younger age, or it can be a variable penetrance where your parents may have it and you may just have a very, very mild, one of your parents has it and you have a very mild case. So there is a broad range of which you can express the gene. So just briefly on essential tremor versus Parkinson's. So essential tremor is considered a benign condition, meaning that it's not associated with other neurologic features. It doesn't have a higher incidence of morbidity and mortality necessarily, unlike Parkinson's. Parkinson's is neurodegenerative. Now, essential tremor can and will often get worse with age, but Parkinson's disease always gets worse over time. You have dying off of the cells that produce dopamine, and it is degenerative and is associated with a higher incidence of morbidity and mortality. Essential tremor, you primarily see that's your classic posture tremor. So when your hands are outstretched, or an action tremor when you do the finger to nose testing with your doctor, or when you're holding the coffee cup or the pen, versus the Parkinson's tremor is primarily the pill rolling tremor that you see at rest. Oftentimes that tremor you'll see more when patients are walking and their arms are just kind of resting where they're walking, and you'll see the tremor. The essential tremor primarily located in the arms, and then occasionally the nodding tremor in the head. You can also see it in the voice, the palate, the chin, versus Parkinson's is primarily in the arms, the legs, and occasionally a jaw tremor. As mentioned, it's benign. There are no other associated features with essential tremor versus Parkinson's disease. You'll see the classic cogwheel rigidity where you'll pull a patient's arm and it's like they're fighting back on you. Bradykinesia, so slowing down. You have them do the finger taps and one hand is tapping like this and the other is kind of doing this. Postural instability, so gait problems. And then with the essential tremor, the patients can oftentimes tell you their handwriting is messy versus Parkinson's disease. More classically, they'll get the messy handwriting, but they'll also get micrographia, the real teeny tiny handwriting. So just a few features that you can look for. So benign essential tremor is the most commonly seen tremor in patients over the age of 40, as Dr. Halpern had mentioned. It affects 5% of the general population versus Parkinson's disease. So Parkinson's disease, although young onset, certainly we see it, is more of a disease of the elderly. It typically affects patients over the age of 60. And even in that population, the incidence is only about 1%. Again, it more commonly affects the arms. It can start out unilateral, but it almost always affects both sides over time. Second most common affected area is the cranial musculature, the tongue, the head, the palate. Orthostatic tremor. So I'm only going to mention this because I talk about it a little bit in medical management. So this is considered a variant of the essential tremor. The orthostatic tremor is basically a tremor where when patients stand up, they develop this high frequency tremor in their legs and they feel like they can't walk. But once they start walking, they get better. So this is different than not being able to stand up because you're weak. And orthostasis, for those of you who are familiar with orthostatic hypotension, which is that drop in blood pressure when you stand up and you get lightheaded and dizzy, they're not connected. You don't have to have orthostatic hypotension to have orthostatic tremor. They're two different pathologies. And sometimes the orthostatic tremor is more of a feeling than an actual visualized tremor. But one way that doctors will diagnose it is that we'll put a stethoscope on our patient's calves and we can hear a classic whirling helicopter sound. And that's caused by a rapid muscle contraction in the legs when standing. But I do warn my patients before I do this, because I had one patient where I had put the stethoscope on their calf and they said, Doc, I think you got the stethoscope on the wrong place. I think you're supposed to have it on my chest. So I warn them why I'm doing it now. Just up here, I actually had a patient with this who there was an article in the New York Times Magazine. She couldn't stand without pain. What was wrong? So it was a patient that I shared with Dr. Tropea, who's a movement specialist down at Penn with orthostatic tremor. And this was a picture from the article. So alcohol in low doses can oftentimes suppress tremor temporarily. If you can get to a threshold where too much alcohol actually worsens it, but it can suppress tremor temporarily. And it's interesting because if you think of why alcohol works, you kind of get to the basis of why we think patients have essential tremor in terms of structurally in the brain. So there's a theory that the olivary nucleus, which is located in the brainstem, which is your involuntary center of the brain, is your central rhythm generator. And so alcohol can temporarily suppress those spontaneous rhythmic discharges that we think may be causing the tremor. Also, the cerebellum, which is your balance center of the brain, has granular cells which express GABA A, which is very sensitive to alcohol. Alcohol binds very tightly to GABA, and we'll talk about other drugs that bind to GABA, and so why we think this may help with tremor. Factors that can exacerbate essential tremor. My favorite coffee, I'm so glad I don't have an essential tremor myself, but fatigue. Extreme temperatures, extreme hot, extreme cold can oftentimes worsen it. Emotional upset or heightened emotion, and then central nervous stimulants. And we'll talk a little bit about medications, but caffeine not being a medication classically will worsen essential tremor. So medications that can worsen it: lithium, used for bipolar disorder, neuroleptics. These are your antipsychotic, Seroquel, Abilify, some of those drugs, and then they are used sometimes for hallucinations and Parkinson's as well, but this is certainly they can worsen any tremor. Valproic acid, which is an anti-epileptic medication, tricyclic antidepressants, so amitriptyline, nortriptyline, used for depression, but also used for migraine prevention and for pain, antihistamines, Benadryl. Anticholinergics I bring up because this is Levsin for irritable bowel syndrome is a commonly used medication, and then Toviaz, oxybutynin, and Detrol for bladder issues are commonly used anticholinergics. Steroids, amphetamines, your ADHD drugs, Adderall, Ritalin, those can all worsen tremor. And then rarely SSRIs, SNRIs, your more classic antidepressant, Zoloft, Prozac can sometimes worsen the essential tremor. So now we'll get a little bit into medical management. So the most commonly used medication for essential tremor are beta blockers, and beta blockers were developed as blood pressure medications. Some studies suggest that there's about a 50 to 60% reduction with beta blockers. The most commonly used beta blocker is propranolol for essential tremor. Now, metoprolol is the most commonly used beta blocker for cardiac issues. And the reason is that propranolol acts on the beta-2 receptors, which are primarily found in your periphery. Your beta-1 receptors are primarily found in your cardiac system. So that's why cardiologists will oftentimes use beta blockers post-CHF or for hypertension, because you're targeting those beta-1 receptors, versus propranolol is found more in the periphery. And so that's why it acts better for essential tremor. Optimal dosage is 240 to 320 milligrams a day of propranolol, and that's a hefty dosage. Starting dosage for long-acting is 60 milligrams. So sometimes getting your patient up to the dosage that actually works, they're not going to tolerate, especially if they don't have underlying high blood pressure. Metoprolol has to be dosed greater than 100 in most cases to see any effect on the peripheral beta-2 receptors. So that is a very big dosage of metoprolol. Starting dosages of metoprolol are generally 12.5 to 25 milligrams. So to get up to 100, again, you're going to see a lot of tolerability issues with that. We do know that if patients don't respond to propranolol, they're generally not going to respond to another beta blocker. And there are other beta blockers other than propranolol, metoprolol. There's atenolol, there's other ones, but those are the most two commonly used. Interesting, the long-acting preparation of propranolol is thought to be slightly better, or at least the same as the short-acting. The reason in my practice that I'll use short-acting is that because this is a blood pressure medication, it's going to drop patients' blood pressure. So if they're coming in with an essential tremor and they run low to begin with, their blood pressure is 100/70 in my office, I may worry that putting them on even 60 milligrams of propranolol is going to drop them too low. So I may start the short acting, because the long acting lowest dosage that it comes in is 60. So I may start the short acting because I can start 5 milligrams of that just to let their system get used to the beta blocker before I put them on the long acting. But I always tell them my eventual goal is to switch them to the long acting once we get to a tolerability from a tolerability standpoint. We don't actually know the exact mechanism of action of why these drugs work. So as with a lot of drugs, especially in the neurology literature, they were developed for one thing, and then the patients with some other neurologic condition came in and said, oh, it made me so much better. Classically, we see that with Botox, botulism, which we'll talk about a little bit later on. Common side effects. So because it's going to drop your blood pressure, it can cause dizziness if it drops your blood pressure too low. It also slows your heart rate, which is why metoprolol is commonly used after open heart surgery to keep those patients' heart rates nice and low. So patients who exercise a lot, especially runners and swimmers who are really trying to get their heart rate up when they're exercising, they will get shortness of breath sometimes with these meds, and sometimes they just feel horrible because they can't get their blood pressure up. So I'm careful when I use these with patients who run a lot. But I have a spin instructor who's been on propranolol for years, and she does fine. So she's really getting her heart rate up there, hopefully. It can exacerbate underlying asthma. It can occasionally cause weight, worsen depression, erectile dysfunction. Just a couple things to talk about. So primidone. So primidone, also known as misaline, was originally developed as an anti-seizure medication. In trials, it's been shown to have a 66% reduction in tremor at a dosage of 250 milligrams a day. So actually you'd say, well, this sounds better than propranolol. That was only about 50 to 60%, but it's much, much less well tolerated, and a lot of drug-drug interactions with primidone, unfortunately. So common side effects, dizziness and sedation is the one you see the most commonly. It can cause some ataxia, some unsteadiness and balance problems. It can cause nystagmus, which is where your eyes go back and forth, especially when you look in one direction, and that can make patients feel like they're moving, or it can make them have difficulty with vision. And then it can sometimes cause patients to feel like they're cognitively a little slower. They just don't feel as sharp. And in some cases, it can actually cause vertigo, which is that dizziness and spinning. Now, these are potential side effects. Not everybody's going to get them if they go on primidone. And I have plenty of patients who take upwards of 750 milligrams a day of this medication and are fine. But I always tell my patients, I'm not going to just give you a medication and say, oh, call me if you think you have a side effect. I go over everything you could potentially get so that you're aware, and then you let me know if you get it, but most people don't. And then the one other thing that I always counsel my patients with this medication especially is that primidone is one of those medications that has first dose effects. So when patients first take it, usually within the first 2 to 3 days, they might feel terrible. But I tell them, if you can start it on a Friday and push through the weekend, by Monday, you should hopefully already start to be feeling a little bit better. Unlike there are some drugs where donepezil, for example, if you get diarrhea on that drug, you're done. You're probably never going to be able to stop the diarrhea until you come off the drug. This drug really, if you can push through those first couple of days that are really uncomfortable, it does get better in a lot of cases. So, and I didn't put it up here, but unfortunately, as I mentioned before, this drug has a lot of drug-drug interactions, especially with your NOACs, your novel anticoagulants, so Eliquis, Xarelto, those drugs that are out and commonly used now. You can't use it with those. Interacts with a lot of other anti-seizure drugs. You have to be very careful with this medication. So that limits it as well. Benzodiazepines. So these are your drugs that were typically thought of more commonly as anti-anxiety drugs. So Xanax, Valium, lorazepam, diazepam, clonazepam, but we use them for a lot of other things. They're anti-seizure medications, and they are good tremor drugs. Clonazepam, which is the longest acting of those of this category of drugs, is generally considered to be the most effective, and it's the only one that helps that orthostatic tremor that I had mentioned before. Well, it's generally thought to be the only one. I do have one patient who uses diazepam, and it really has been helpful for her, but it's generally considered to be the only and most effective for orthostatic. Alprazolam is actually considered to be the second most effective medication for essential tremor in this class, and that's Xanax. But we don't know if it's more that it has an anti-anxiety benefit. And so, as I had mentioned before, essential tremor is worsened with high levels of stress and high levels of emotion. So calming that anxiety may be more of a benefit that you're seeing with the alprazolam. Alprazolam is your shortest acting of your benzodiazepines, as well as your highest potential for addiction. So the main side effects to these drugs, they don't have a lot of drug-drug interactions. You want to counsel your patients not to drink the alcohol with them. But typically the biggest side effect you're going to see with benzodiazepines is just that they make patients really tired. But they can lead to dependency and addiction. So you have to be very careful, especially if you're treating someone younger with these medications. Gabapentin, again, developed as an anti-seizure drug. But we use it for, nowadays, we don't use gabapentin for seizure nearly as much as we use it more commonly for neuropathic pain. So pinched nerves in the neck and the back, diabetic neuropathy, and other forms of neuropathy. We use it a lot for migraine, and it is actually used for anxiety. So it's been shown to be effective in small studies. However, it does require high dosages to be effective. So starting dosage of gabapentin is usually 100 milligrams 3 times a day. Most studies suggest that you're not going to see a tremor benefit until you get closer to 400 milligrams 3 times a day. And the majority of the patients need between 1,800 and 600 and 3,600 milligrams. So that's a fairly hefty dosage of this medication. This medication has very prominent dose-dependent side effects. So the side effects with gabapentin almost always occur as you're increasing the dosage, which is why that's what really limits the use of it. Side effects: sedation, dizziness, weight gain, and you are going to see them as you increase the dosage. Topiramate, which is another anti-seizure drug, is in the carbonic anhydrase inhibitor family. Now, there are other carbonic anhydrase inhibitors, such as Diamox, that were used more traditionally, but we really don't use that anymore for essential tremor. So we know that this works by enhancing GABA. And as I had mentioned before, we think those We know those cerebellar granular cells are especially responsive to GABA. So that's why we think some of these GABA acting drugs, again, benzodiazepines also act very strongly on GABA. Primidone acts on the GABA. Topiramate was developed as an anti-seizure drug because a lot of anti-seizure medications act on the GABA receptors, but it's FDA approved for migraine prevention as well. We use it off-label for neuropathic pain, especially trigeminal neuralgia, and I have seen psych use it off-label as well for anxiety and bipolar. Topiramate is a very commonly used medication because it can help you look like Miss Olive Oil here. Its number one side effect is weight loss. Patients lose about 10% of their body weight on this drug in some cases, and it is appetite suppression, so it kills your appetite. It can cause numbness and tingling in the fingers and toes. It's not dangerous, but it freaks your patients out if you don't warn them about it. The classic limiting side effect to this is that it can cause some word finding, tip of the tongue difficulty. In the Topamax is the brand name for it. Neurologists used to nickname it Dopamax because it made people feel like they were stupid in some cases, and it can cause reduced sweating, so you have to watch out for that. It's also associated with kidney stones, so if your patient has any history of kidney stones, they really should not use this drug. Botulism, Botox, as I mentioned before, originally developed for cosmetic purposes. We use it for migraine prevention. We use it as a muscle paralytic for dystonia. This is most commonly used for head tremor, the palatal tremor, and then a hereditary chin tremor. This I would caution you if you see a general neurologist. I generally defer to the movement disorder specialists who do a lot of this for essential tremor. And then sometimes the ENT specialists to do the Botox injection, because it has to be injected in the throat. It can cause dysphagia, so it can cause swallowing problems when your patients get this. They can get this painful compensatory muscle contraction in their neck and get a lot of secondary dystonia. And then rarely it can affect respiration. So physicians who are doing botulism for essential tremor really need to be well-versed and have a lot of experience using this. So that's what I have for you. I think I stayed in my 20 minutes and I've got 10 minutes for questions. These are my girls. This is my other girl. She's remained quiet during this presentation, which I was a little worried about. So I can take any questions that people may have.
Thank you, Dr. Feldman. It looks like there's some comments in the chat from patients that have tried gabapentin and primidone and have had those negative side effects you were saying.
Okay. I think I have to this to see the chat.
Yeah. So someone had mentioned they are on gabapentin, but according to the internet, it's not an EP medication. Propranolol made asthma way worse.
Yes, it definitely can do that.
And then there's a question, any clinical on young onset or any clinical trials on young onset?
I'm sure there are. I'm not aware of them. Dr. Halpern, do you know of any clinical trials for young onset for medications? I don't know.
Yeah, I'm not aware of any either.
I'm not either.
This gets back to the forgotten disease.
Yeah, exactly. And as I had mentioned at the very beginning of the talk, there really aren't a lot of options. You've got beta blockers, which are antihypertensives. You've got primidone, and then you've got benzodiazepines, which are addictive, and then you've got, well, sometimes topiramate, sometimes gabapentin, maybe Botox will help, but really you have 3, maybe 5 choices of what's going to help, because switching within class doesn't help. If you don't respond to topiramate, the other carbonic anhydrase inhibitors don't help. If you don't respond to propranolol, the other beta blockers don't help. So you don't have a lot of options out there. And I'm not aware of any clinical trials.
Dr. Feldman, when I see patients for essential tremor, I tend to tell them that in general, and I of course, there's other medication trials that are worth considering, but that it's all about the 3 Ps, and they usually already know about propranolol and primidone. And then they're wondering what this third P is. And that's, obviously with my, surgical background, that's procedure. But, I think it is important for people to realize that benzos like Xanax or Topamax, gabapentin, could be helpful. And we certainly see patients who have benefited from them as well in our surgical clinic. And sometimes we feel like a procedure might be high risk for some reason. So then we bring in those other agents as well. But it was intriguing to me. I learned a lot from your presentation that the dose really matters. If you start at a low dose and there's no side effects, but there's no benefit, that doesn't mean it's not helping you. It just means you got to go up on the dose.
Yeah,
So
unfortunately.
And there actually is a question here. What is a common dose to start propranolol?
So for long acting, 60 milligrams is the common starting dose. But as I mentioned, a lot of the times you've got to get up to that 240 to see a benefit, which can be very, very challenging. And then, so long acting, the smallest dosage, the smallest preparation it's available in is 60 milligrams. And I almost always do it at bed. But short acting comes in 10 milligrams, and you can split those tablets. So for patients who already have low blood pressure, who say, I'm sensitive, I get every side effect, sometimes I'll start them on 10 milligrams twice a day and tell them to take a half. Short acting should be dosed at least twice a day. Sometimes we dose it 3 times a day. And then obviously patients with gastric bypass who can't take long acting preparations of medications, they take the short acting. So that can be helpful. Somebody else had further down, there's a question, and my brother is a guitarist and he uses it as needed, the propranolol. I do have some patients who do that. I have patients who are very sensitive to anxiety, and propranolol is commonly used actually for stage fright. So some people will use it just before a big presentation, or they'll use it, a performance or somewhere where they know they're going to be on a heightened state of anxiety. I have some patients who only take it on days that they work, and they don't take it if they don't work. If they're a nurse and they have to start an IV and they know their hand's going to be shaking, they'll use it on those days. So some people do take it as needed. My patients who are able to do that tend to be, I call them super responders, patients who take a very small dosage and get a robust benefit to it. And I have those patients. I have people who 10 milligrams is all they need. Some people are very, very sensitive to medications.
And there's a question, are there any concerns when these medications are used with other seizure meds in patients with well-controlled epilepsy?
So the anti-seizure class is not necessarily going to make their seizure drugs less effective. Now, primidone is it has to do with the way that they interact. It has to do with the enzymes that they kind of chew up. So primidone, when used in combination with certain other medications, can lower levels or it can raise levels. But certainly if you're seeing a neurologist, they should be aware of the potential interaction. So the only interaction is that it may raise a level or lower a level, and you've got to really be careful with checking drug levels in some of those patients. Some of my patients are able, if they have well controlled, can oftentimes come off of their other anti-epileptic medication and just be on one drug. So that can be useful too.
And looks like Dr. Cajigas did answer one of the questions in here, if it's common to see essential tremor in legs. So it looks like there's one last question, if exercise is helpful.
So exercise is probably more beneficial in helping with lowering anti-anxiety. I don't know that there's necessarily any data, unlike Parkinson's, where there's clear data. There's been animal models where we've looked at exercise and we've actually lesioned the brain, and we've seen that there's, animal in monkey data that monkeys that exercise have a slower rate of loss of dopaminergic cells. Now that is animal models. You have to take that into account. But in Parkinson's, we definitely think and are fairly certain that exercise is beneficial for the disease. With essential tremor, there's no clear data on that. We're also not doing animal models, and it's genetic. So you wouldn't necessarily see anything when you lesion the brain. But certainly the anti-anxiety properties are good, and occupational therapy, good hand therapy can be very, very useful. And someone also mentioned CBD THC. I do have some patients who think medical marijuana can be useful. The data is actually that in general, it's 50-50. Some patients get a benefit, some patients don't. It's not, I don't use medical marijuana typically first line, or I don't use it a lot in my essential tremor patients. Most of them come back and say that it does not work. unlike tremor for Parkinson's, which can be exquisitely sensitive to THC, there are a lot of cannabinoid receptors in the basal ganglia, and those patients will often have a very, very robust response to THC. You don't see it as much with the essential tremor patients. And again, the benefits of THC may be, for essential tremor, may be more anti-anxiolytic, like we think alprazolam Xanax is.
Okay, great. I think that is all of the questions that were in the chat here. So thank you, Dr. Feldman. Next, we're gonna move on to, is deep brain stimulation right for me? And that is gonna be with Dr. Iahn Cajigas. Dr. Iahn Cajigas's clinical expertise includes PS, focus ultrasound, stereotactic radiosurgery for movement disorders, management of refractory back pain with neuromodulation, and the surgical radiosurgical treatment of trigeminal neuralgia. Research focuses on understanding the real-time control of movement by the cortex and spinal cord using state-of-the-art intraoperative techniques. This understanding can empower the next generation of functional neurorestorative therapies and devices. Dr. Cajigas completed his residency at the University of Miami-Jackson Memorial Hospital and his fellowship at the University of California, San Francisco. He joined Penn Neurosurgery in 2021.
Great. Thank you so much for the introduction to Gabby, and thanks to Dr. Feldman for a great summary of the medical management strategies that are important to sort of first-line therapy for helping patients with essential tremor. I'm going to just share my screen and this up here. Everybody see my screen okay? Make sure the sound is shared. All right. Here are my disclosures. So my goal today is to talk about is deep brain stimulation the right option for you? Like Dr. Halpern said, they're typically, we talk about the 3 Ps, primidone, propranolol, and procedures. This is one of the 3 the procedures that we can do to help patients with essential tremor that remains bothersome and is affecting your activities of daily living despite adequate trials of medication. You know, it may not be the right option for everybody, but it is one of the options that's available. And our job today is to sort of summarize the available options and help you navigate them. So as an analogy, DBS is very much like a pacemaker. And I like to think about how we intervene in the brain with either ablations or with stimulation, just like we do in the heart. So to make that analogy, think about heart and its rhythm, right? The beating of the heart is very important in its function. And you know, when the heart is not beating normally, you get problems in the body with circulation. And so cardiologists have tried to fix the problems with the abnormal rhythms in the heart by either pacing the heart in a very controlled way, so you can restore those rhythms and the heart can work as a pump back as it normally would, or we can create ablations in the heart to fix the conduction of the abnormal electrical activity. And so those are going to be the 2 main options we'll discuss today, either ablations in the brain or stimulation in the brain. And you can think about essential tremor, just like these abnormal rhythms in the heart cause it to dysfunction. These abnormal rhythms in the brain's electrical activity manifest as tremor. And our job with DBS is to disrupt that abnormal circuit to restore the normal rhythms and therefore help with the tremor. We can do the similar things with the ablations by disrupting those abnormal circuits to restore, again, the balance of the normal electrical activity. So what does that actually look like? So deep brain stimulation involves the placement of a lead into the brain, deep into structures such as the basal ganglia, which are very important in the regulation of movement, or in the thalamus. In essential tremor, that area where we put electrodes is typically in an area of the thalamus called the ventral intermediate nucleus, or the VIN. You might see in different web searches if you're looking up these interventions. And it's really just a node in the thalamus that is very important in the synchronization of information between the motor cortex that's sending the signals down to the body and also receiving signals from things like the cerebellum, and integrating that information to allow movement to happen smoothly. And so that is the brain target that we use for deep brain stimulation in essential tremor. The system is then connected with leads that go under the skin, down behind the ear, down to the level of just below the clavicle, just like a pacemaker would sit. Think about it again as a pacemaker for the brain, restoring the normal electrical balance of rhythms. On the right-hand side of the slide, you'll see that there are many different devices, that give us different options in terms of the management. And our job, when we're considering deep brain stimulation as a therapy, is to go over the pros and cons of the different devices so that we can help find the best device for you. There are rechargeable and non-rechargeable devices, which you see the rechargeables on the top end here, a little bit smaller because they don't need to carry all of the charge in them for the longevity of the device, and the non-rechargeable devices that are here in the bottom, which are a little bit bigger. The non-rechargeable devices can last 15 years before they need to be replaced, whereas the non-rechargeable devices last 3 to 5 years, depending on how much stimulation is being used. The recharging for the rechargeable devices with all of the new versions, usually it takes about 30 to 40 minutes once or twice a week. And we can go over the details of how that happens. Just for context here, this is one of my neurology colleagues' credit cards. Unfortunately, the number is not visible. So just as a reference, in terms of the relative size. You can see they're quite small. The battery that you see here on the bottom left is a Medtronic Percept PC, which you can see just from the shape here. You can see it's a little bit bulkier than the corresponding rechargeable. And you can see that the incisions are small, that the new devices are low profile. You can barely see that there's anything under there. You can see just a remnant of the prior incision. So at Penn, Dr. Q, Dr. Halpern, and myself tend to do the DBS surgery in 2 parts. This is the first part is where we place the electrodes into the brain. This requires using a specialized frame that is used to keep your head really still while we do the procedure. It also gives us a special coordinate system for the brain, an XYZ coordinate for every point in your brain that we can then use to precisely get the lead to the brain target. We confirm that the lead is in the right spot using a combination of an MRI that you obtain before surgery and this frame that we use in surgery. We also sometimes record from your brain, which I'll show you some examples of, to make sure we're recording from the right types of cells. And then lastly, we tend to use an awake testing to make sure that the stimulation not only is helpful for the tremor, but that there are no side effects to the stimulation. The benefit of this is if there are any side effects, we can do repositioning of the electrode with millimeter accuracy to a new spot that will have the same improvement in the tremor and the lack side effects. On the top here, you can see an example of the type of testing we might do in the OR. We don't bring in glass cups here at Penn. This is an older video, but we might do things like intraoperative spirals like this, just so that we can compare once the stimulation is turned on, that the tremor actually gets better and that the spirals improve. The surgery takes about 1.5 to 3 hours, depending on whether one side or both sides are being done. And this is a really important thing when considering the type of tremor that's present, if it's affecting just one side of the body or both, and knowing that with DBS, sometimes we can actually address both sides simultaneously, whereas with things like focused ultrasound, we can only target one side at a time, just because of the risk profiles and the approvals from the FDA. After the surgery is concluded, we take that frame off. We typically leave the leads coiled behind under the skin, sort of just at the top of the head on one side. You spend the night in the hospital, and let's say about 95% of patients go home the next day. About 1 to 2 weeks later, we do a short outpatient procedure that takes between 30 and 40 minutes to connect the leads from the head down to the battery that sits at the level of the clavicle. We tend to place the battery on the right side so that if you ever need a pacemaker in the future, that typically goes on the left. But there are certain circumstances that we will put it on the opposite side, particularly if folks that like to go hunting and might want to carry a gun on that side. We don't want that kickback to affect the battery, so we can definitely move it. Sometimes also if folks have had surgery on that right shoulder and it's uncomfortable, or had fractures and it's just not the best location for them, we can place it on the left. And actually, sometimes if neither the left and the right is an option, the battery can be placed in the abdomen. We also, across all three of our colleagues on the neurosurgical side, we tend to turn the system on at a low dose, typically when we implant the battery, just to start getting some relief. But the ultimate management is by our colleagues in neurology, like Dr. Feldman, who will then optimize the stimulation as over time. So, as I mentioned earlier, deep brain stimulation, we're using electrical stimulation to disrupt abnormal signals in the brain rather than creating an ablation or a lesion. There are pros and cons to any intervention, and in the clinic, we will discuss these with you in detail. The main pros for deep brain stimulation is that it is reversible. This is something that we can place an electrode there, and if for any reason we need to remove it, say there's an infection or it's just not an effective therapy for your treatment, which is very, very rare, I should say, we can remove the equipment and the brain is not injured. It is adjustable. So if the symptoms change over time, we can make adjustments in the office without another surgery, just by using a special patient programmer to give more stimulation and help with the symptoms. Now, important to understand that this is not curing the essential tremor, or if this were a Parkinson's tremor, the condition may change over time. This is not a cure for that, but it can be a very effective treatment. And if the condition changes over time, this gives us an adjustable way in the clinic with low risk to account for those changes. As I mentioned earlier, we can typically treat both sides of the body at once with deep brain stimulation. The rechargeable batteries can last 15 years before they need to be replaced, and the non-rechargeable batteries last between 3 and 5 years before they need to be replaced. The replacement procedure, just like that second procedure I mentioned, is about 30 to 40 minutes outpatient procedure where we just open that area, remove the battery, put in a new battery, and replace it under the skin. The downside is it does require, putting the electrodes into the brain, which is associated with risks, which are small but not zero, and may be different depending on other risk factors that patients might have. If folks are on anticoagulation or the high risk of falls, that might be something that gives us some pause about the risks associated with placing the leads into the brain. Additionally, there's a need for an implanted device, which carries risks associated with infection, as does any surgery where you're implanting something permanently into the body. And some patients may not want to deal with the follow-up that needs to happen regarding the implanted device. So this is why it's a very personalized discussion that needs to occur between your neurologist and your neurosurgeon to help you identify the best option. So what gets better? Here we're talking about essential tremor. I have to say that it is remarkable the extent at which tremors improve with deep brain stimulation. What other things that I list here, this is primarily for Parkinson's associated tremor or Parkinson's disease, where we can get improvements in slowness, stiffness, the amount of off time, that is the time that medications are not working. We can sometimes decrease medications. In essential tremor, we usually are able to decrease medications significantly, if not completely. And these other things we can talk about on a one-by-one basis if you were interested in a surgical consultation. Things that do not get better or may actually worsen. So, this is not a cure for the disorder, and we are disrupting brain networks in order to make this work, right? So, the motor coordination of speech and the motor coordination of balance can be affected by placing an electrode in this area. The benefit of all the new devices is that they give us the ability to steer the stimulation in different directions. So we can usually optimize settings so that we get very good tremor control with very little side effect of speech and balance. But they can be affected just because there's an electrode there in the brain. I would say also that sometimes it's not possible to get perfect tremor control and not get these side effects because the electricity spreads from the area where it's being applied. So, I'll give you an example. As a fellow, I had a patient who was a concert pianist, terrible essential tremor, could no longer play the piano, had deep brain stimulation, incredible response, able to get his hands very steady and get back into playing the piano, but very high levels of stimulation were required where he was not able to speak very well at his normal pace. He had a little bit of slowness of his speech when he had perfect tremor control. So he actually has two settings on his DBS, one that's his piano setting where his hands are super steady and speech is a little bit affected, and as a second setting where there's a little bit of a tremor, but the speech is normal. And so it may require some optimization in your particular case to get you the right balance of tremor control and no side effect. And that's really where sort of having a good team relationship between your neurologist and your neurosurgeon is very important. How long does the stimulation effect last? All of the data that we show shows that the effect can last for many, many years. But however, it does not change the progression of the underlying disease, whether it's Parkinson's disease or essential tremor. So it is possible that some of the loss of efficacy over time is just due to the severity of the symptoms getting worse. What we do know is that in uniformly all circumstances, if you turn the stimulation off, if there is a little bit of breakthrough tremor, the tremor is actually significantly worse off stimulation. There are certain things that folks try to do to decrease any potential sort of effect where the brain can get used to the stimulation. We have some patients that turn off the stimulation at night just to prevent the brain from being exposed to the stimulation 24/7. And that by some is argued that can help increase the duration of time. But we have patients that have had DBS for decades with continued significant benefit from their stimulation. How do we do this? Again, in the OR, we use a special apparatus that's connected to a frame to very precisely target a spot in the head where we're going to enter with the electrode. And then we listen to the brain as we advance that electrode down into our target. In the essential tremor, that target is in the thalamus. This is for a patient with Parkinson's disease where we're putting the electrode down in the substantia nigra. And we can actually listen to the cells as the electrode advances down, and the cells have different characteristics that help us determine where we are. This is an example of a patient with Parkinson's disease in the next video, just showing how we know we're in the thalamus here. You'll hear a cell that's firing at the same frequency as the tremor. And so we use the knowledge of the characteristics of the cells to kind of know where we are, and that helps us fine tune the placement of the electrodes. We do, as I mentioned, also test for the effect of the stimulation on the control of the tremor to guarantee that not only are you going to get benefit from the stimulation and avoid side effects. So this is an example of intra-op testing. When I was a resident, a patient with essential tremor, they're holding up a little bottle of alcohol. They're not going to drink from that, but it's just to represent sort of bringing something up to your mouth to drink from it. And you'll see it shaking when the stimulation is off, and then you'll see it stop when the stimulation is turned on.
Keep it up there. Keep it up there. I'm going to turn on the stimulation right now. And now I'm gonna turn it off. And I'm gonna turn it back on. And then I'm gonna turn it off.
You can see how dramatic of an effect that is. And then what we do is that we can check for side effects. This is another example of how dramatic things can get in the OR with control of tremor when the stimulation is turned on. You can hear everybody in the OR going like, wow. You could even say somebody say, "Who's your daddy?" because they're so excited. This is an example of a patient of mine a year ago offered to share his story regarding his experience with essential tremor. So I'll let this video play and just read the captions here at the bottom.
Okay, right. It's a challenge. So it's isolated.
That was a very unique circumstance because when I met Jim, he had his daughter's wedding coming up pretty soon, and we wanted to make this happen for him. So this was one circumstance where we did both the lead placement and the battery at the same time. And this is just the initial settings that I put it in the post-op recovery area immediately after surgery. So needless to say, we've gotten actually a little bit better tremor control over time. You can see pre-op from the top left on the left hand and immediately afterwards on the bottom, and same in the right side. On the right, you'll see this is how we target our electrode. This shows where the electrodes are in the thalamus, this pink structure, and an important fiber tract that we target, which is called the dentatorubro-thalamic tract, and its relative location based on our electrode and the nucleus as well as the tract. This is a procedure. This has risks. It is not perfect, but it is generally quite safe. What are the main risks of the procedure? The first is there's a small risk of bleeding in the brain because we're putting an electrode into the brain, and this can be slightly different depending on other medications that you might be on. So there's a small risk of stroke or bleeding in the brain, and then there are risks related to anesthesia. So just problems with the heart, lungs, clots in the legs that can happen with any surgery. Depending on age, the post-op course is generally well tolerated, but older patients, with a little bit of anesthesia, there's a risk of having some post-operative confusion or just being a little bit tired. The risk of seizure is possible, but very low. The main or the largest risk with any implant surgery is the risk of infection, which is about 3%. Side effects of the stimulation I mentioned earlier, there can be changes in speech or balance. Additionally, the motor nucleus in the thalamus is very close to the sensory nucleus in the thalamus. So particularly when we turn the stimulation on or off, you might feel a transient sensation of tingling or numbness in the hand. That usually goes away as the brain gets used to the stimulation. There are some typical restrictions, particularly after surgery, just to make sure the healing goes well, particularly in terms of we're treating your headache or anything afterwards with narcotics, which is not common, but we would recommend no driving during that period. Also, there can be a little bit of swelling around the electrode, particularly within the first 2 weeks. So we definitely tell folks to take it easy during that 2-week mark, to not have any big work responsibilities, things that are going to get in your way of just taking some time off and letting things swelling go down over time. Because we do open a small opening around the electrode to place it into the brain, we try to avoid heavy lifting or bringing the head down below the level of the heart, because this increases the pressure around that area and may affect healing. What are your typical post-operative expectations? There's something we call a honeymoon period or lesion effect. Sometimes just placing the electrode into the brain itself can lead to benefit or improvement in tremor, even if the device is not turned on. This can last anywhere between 1 and 2 weeks, and the symptoms will get better initially, but over time they will return as the swelling around the electrode goes down. This is normal. It does not happen to everybody, but does happen to some patients. And again, the symptoms will start getting well controlled once the programming is done. The initial programming can typically happen about 4 weeks after the lead is placed with your neurologist. If it's a Parkinson's tremor, we tend to see patients off their medications to review which contacts are better. For essential tremor and Parkinson's at Penn, we tend to turn the device on at a low dose initially to start providing some relief, with the understanding that the ultimate programming decisions are going to be made by our neurology colleagues. During the first 3 to 6 months, there are several visits to optimize settings to find the best ones that minimize any side effects, as well as if there are any medications that need to be weaned, that they're weaned carefully as the stimulation gets increased. This can take anywhere between 3 to 6 months, particularly for essential tremor. For Parkinson's and other tremor conditions may be longer, 6 to 9 months. So everything gets adjusted according to how you're doing over time. And you also get some control of the settings yourself. So Dr. Feldman might set program 1 and give you a limit from stimulation of 0 to 1 milliamp. And at home, you go up a few clicks, 1 click every few days to slowly titrate the stimulation to comfortable levels. And there are some long-term restrictions or things just to be aware of when having these types of permanent implants. This is changing based on recommendations from the infectious disease doctors, but you used to recommend initially after surgery to have some antibiotics when having dental procedures. Evidence for this is kind of changing. And so it may not be something that needs to happen, but you should just review these with your particular surgeon after your surgery if you have any immediate procedures in the first few months. Recharging, if it's a rechargeable battery, is very important. We just recommend that it's something that you get into the habit of doing at least once a week. There are certain medical procedures that may require you to turn off your stimulator, like getting an EKG or having another surgery. You should bring your DBS programmer and or recharging devices to your appointments, or if you have a hospitalization for any other reason. And our reps from the different companies are phenomenal, and they will you could let them know, I need to be in this hospital for this procedure, and they're great at connecting you to the right folks. If you do need an MRI for any reason, you usually have to touch base with us to have a form filled out to get an MRI. And then when going through the airport, you would go through pat downs instead of the standard metal detectors, because the electrical interference that can be generated by the machines can affect the device. Just like watches aren't rated to go below certain depths, FDA never really did the study to check for DBS in skydiving or scuba diving. So these are off-label uses, although I have patients that have done the scuba diving off-label with no issue, but it's not technically within the scope of when the device was developed for. Direct contact to the device is definitely not encouraged. And things that need to happen, but you should be aware of, you need to have a defibrillation that might clear the battery settings or damage the battery, but we can always replace the battery if that needs to occur. And importantly, with DBS, if you're thinking about other trials, particularly in Parkinson's, there are studies on stem cells and the like. Doing some of these current standard of care procedures may affect your ability to participate in clinical trials because they try to recruit patients that have not had prior interventions. But the benefit of the stimulation is so dramatic that it is one of the best things that we have right now to help with these symptoms. Lastly, it's really a team and that works with you. If you do get DBS, a combination of your neurologist that will help with stimulator programming, managing medications, and doing the titration, neurosurgery, which will work with implanting the leads in the battery, answer questions about the wounds, and any battery replacements, and lastly, the device manufacturer, which can help you with recharging or any programmer issues, and we all work together very often. So with that, I'll end. These are the locations where I currently see patients. All of our surgeries are done at Pennsylvania Hospital, and I'd be happy to take any questions. Sorry for going a little bit over.
Okay, looks like there's a couple minutes left if anyone has a question. A couple of patients did mention, or if there was some sort of age restriction, whether DBS can be done on like a 38-year-old versus a 78-year-old.
Yeah, so age restrictions, none that are sort of, it's depending on your overall health. When this can be done, it's up to you, the neurosurgeon and you. I'll tell you the youngest patient with essential tremor I've done is in their early 40s. 30s would not be a problem. The oldest patient I've done DBS on for tremor was in their 80s, 85. So, age is just a number, as they say. It really depends on your other medical conditions and the pros and cons of doing something like this versus something like focused ultrasound. And it's a very nuanced, personalized discussion between you, your neurosurgeon, and your neurologist as to what your best option is.
Is there any risk for dementia?
So it tends to be independent of what we're doing. Certainly, there can be cognitive changes associated with things like Parkinson's disease that this would not alter, but certainly there's no risk of sort of precipitating a dementia or severe changes in cognition with this device. If there is any concern cognitively prior to doing the DBS, that is, we typically do a screening in the office to get a baseline of where folks are cognitively. If we have any concern, we typically do a full neuropsychological assessment to make sure we identify what the cause of any cognitive change is, to try to optimize folks prior to surgery to make the process as smooth as possible.
Okay, great. Thank you, Dr. Cajigas. So the next topic we're going to review is focused ultrasound. So if that is the right option, and that is with Dr. Li-Ming Qiu. So Dr. Li-Ming Qiu completed a residency in neurological surgery at the National Neuroscience Institute in Singapore and attained specialty accreditation. He then underwent a 2-year postgraduate fellowship training in stereotactic and functional neurosurgery at the University of Pennsylvania. Dr. Qiu's clinical expertise includes deep brain stimulation and focused ultrasound treatment for movement disorders and neuromodulatory management of chronic pain disorders.
Thank you, Gabby, for the introduction. I'm going to put up my slides. Do you see my slides? Can you hear me?
Looks great, Li-Ming. Just make sure to have clicked on the sound option for your videos.
Yeah. All right, good. So I'm going to talk about focused ultrasound for essential tremor and is it right for you? So some of the considerations that we make when we see patients in the clinic to decide whether, yeah, good candidates for focused ultrasound. So what is focused ultrasound exactly? It is a novel technology that has been developed in the recent years. And unlike deep brain stimulation, which Dr. Cajigas mentioned earlier, it is one of what we call an ablative technology. What that means is that we use this technology to heat up the tissue to destroy some of the cells in the brain where we target precisely to stop tremor. So what it does is to harness the power of sound waves, what we call acoustic energy. And how it works is by using more than 1,000 ultrasound beams and converging them all together. And at that point where ultrasound beams comes together, it heats up the tissue right at that point. You can see here in this diagram, only when the beams come together does a temperature temperature increase and heats up the tissue. So throughout the path of each of one of these 1,024 beams, nothing happens in that path. And this technology, compared to other ablative technology that was developed before, it has advantages, mainly because it's more precise. We can make smaller lesions. There has been proven improved safety profile. We are able to use real-time technology with this, real-time imaging technology with this focused ultrasound to make sure we are treating in the right spot. We can monitor patients because they are awake in this procedure, as I will show you in a short while. There are no radiation side effects compared to radiation such as a gamma knife. It's an outpatient procedure, meaning you come in for the treatment, you go home on the same day. There's no implant, unlike DBS. I will discuss some of the factors to consider, however, because not every patient is suitable for focused ultrasound. And the targets we use for focused ultrasound is similar to deep brain stimulation that Dr. Cajigas talked about earlier, especially for essential tremor patients. So this is a short video of how focused ultrasound looks like. So everything is done in the MRI machine. You can see here, there's a head frame, the same one that we use for deep brain stimulation and focused ultrasound. We use imaging technology to help us with the targeting. So we plan the target beforehand, and we instruct the machine to direct the beams at where we had planned the target. There's no radiation, as we mentioned. So because it's a new technology, we have had to show that this focused ultrasound technology is better than what we had before. So there was a lot of research that went into developing this technology, and since 2016 it has been approved for the treatment of tremor, first with essential tremor and subsequently for Parkinson's disease-related tremors and movement disorders. So you can see here in 2016, it was approved for treating one side symptoms for essential tremor. And very recently in 2022, it's now approved for second side treatment, meaning patients who had treatment for one side, they can now come back to treat the other side. However, I would say that you have to wait 9 months between the two treatments. And the reason for that is because historically, it's been shown that treating both sides at the same time is associated with more side effects. So when this was developed, research has been done with it being staged, and that has been shown that to have a more safer profile. So these are the studies that I mentioned before that have been done before focused ultrasound was approved as a treatment. So you can see here at baseline, patient has very high tremor ratings, and after treatment at 1 year, 2 years, and 3 years, there have been sustained improvement in tremor. The latest study showed at 5-month follow-up, there is still sustained improvement in tremor. So you can see here, if I direct your attention to the blue bar chart. So this is at baseline. So patients has a lot of tremor, and so this is 1 year, 2 year, 3 year, and up to 5 year. There is significant improvement in tremor. However, if you look closely, some patients did have some return of tremor, but that's minimal. So in this study at 5 years, there are reports of side effects, which I'll come into in a short while as well. So patients have reported side effects. The most common that we see are imbalance in gait, speech difficulty, and things like tingling and numbness. And the reason for that is because, as I mentioned, this is an ablative therapy, which means we destroy the tremor zone as precisely as possible. However, in the thalamus, where we do the treatment, it's very close to other important cells. And these are the cells that are involved in gait balance, sensation in the hands, and speech. So especially immediately after treatment, in the first week or so, there's swelling, and that's when patients start experiencing some of these side effects. Most of the time, I would say more than 90% of the time, these are transient. As the swelling get better, the side effects tend to go away. Although I would say that a small percentage of patients tend to have long-term side effects. And these are the patients we are usually more careful of, and we screen thoroughly before we recommend a focused ultrasound procedure. This is a very recent publication of a bilateral thalamotomy. Again, there's been sustained improvement in tremor, minimal side effects that are long-term. So because of this new technology that's been around since 2016, I'm sure some of you have heard that of this more being mentioned more and more. And we as providers and physicians who provide this treatment, we've seen a growth and a lot of interest in this treatment because it's non-invasive, meaning we don't need to make an incision. And there's a lot of interest in this, and we've seen a lot of growth and patients asking for it. So what should you expect and what happens during the procedure? So first of all, one thing to mention, if you're not aware, is that even though this is a non-invasive procedure, patients do need to shave all the hair. And the reason for that is because this harnesses the ultrasound waves. And if you recall high school physics, ultrasound doesn't work very well with air. And with hair, it traps some air, and that may deviate the beam of the ultrasound, and that makes things the technology inaccurate, and we don't want that. So in order to have focused ultrasound treatment, the patient does have to shave all the hair, and that's one consideration for patients. Some patients do not like that. Again, we do all the planning beforehand. We do a high quality MRI and CAT scan before the procedure, and we do all the planning and calculation beforehand. During the procedure, we'll get you to do the spirals that we do in the clinic, and we'll do that several times to make sure that the treatment is effective and there are no side effects. So this is a video.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects. During the treatment,
So the benefits of focused ultrasound, like mentioned, you can see immediate and durable tremor improvement on the day of procedure. You can see immediate improvement. Most of the patients go home the same day. There is little to no risk of infection, unlike deep brain stimulation, because we don't make any incision. The only thing is we put pins. So there are small pin sites when you go home on the same day. There are no implants, no anesthesia. We keep you awake so that you can communicate with us, whether you have side effects, and we can assess the tremor throughout the treatment. During the treatment, however, some patients do have discomfort, and these are things like pain. Some patients complain of dizziness or sensation of nausea. Again, you're completely awake during the procedure, so you can tell us if you have any of this sensation, and we can let our anesthesiologist know, and we can give you medication during the treatment. Now, depending on the patient's skull properties, for some patients, we need to give higher dose of energy. For these patients, sometimes they have more scalp swelling or discomfort after procedure. And again, the swelling tend to happen, 1 or 2 days later. It may not be seen on the day of procedure. So we have some patients calling up 1 or 2 days later, complaining of swelling or the eyes not being able to open. We do see that sometimes, so that's not something to be extremely concerned about. So again, this is an example of a patient pre and post focused ultrasound treatment. We often see dramatic improvement in the spirals, and they can immediately start using their hand. And a lot of times, we are told by patients that, they haven't been able to do this for a long, long time. So they do see a dramatic improvement in the tremor. It is also now approved for Parkinson's disease, both for tremor as well as other symptoms, motor symptoms of Parkinson's disease. So who is eligible for this treatment? For essential tremor, the criteria is that you have to be an adult, age above 22 years old with a confirmed diagnosis of essential tremor. You have to have tried medical treatments before, mentioned by Dr. Feldman earlier. For second site treatment, as mentioned, we have to wait for 9 months between your first treatment and second treatment. And for both essential tremor and Parkinson's disease, some of the other criteria we look out for is the patient should not have contraindication to MRI, because the whole treatment is done within the MRI environment. The patient should be able to lie flat in the MRI machine for about 2 hours altogether. Some patients are unable to do that, and because of the positioning and the need to be with the head pin, we have had patients not able to do that. So that's one of the things to consider as well, whether you're suitable for this treatment. And of course, the ability to communicate with us during the treatment and press the sonication button if needed, as you saw earlier. So again, what to expect? So if you are considering whether you're suitable for this treatment, you should ask your neurologist or book an appointment to see us, and we can talk to you about what to expect and discuss all the nuances of whether you're a candidate or not. So pre-surgery, again, we order a high quality MRI and CAT scan. Now for focused ultrasound treatment, because it uses the ultrasound technology to pass through the skull into the brain, there is a property in the skull that we would calculate. We call this the SDR. It's a number. So that's a calculation we do on our side once we get the CAT scan. Basically, it tells us how efficient your skull is for the ultrasound beam to pass through. So for some patients, the number is a little low. That basically tells us that we have to prescribe a higher dose of energy in order for the ultrasound beam to pass through. So if we find that, we would usually, give you a ring or arrange a consultation either over telemedicine or in person to discuss with you again. So we usually tell patients that, this is our calculation. we know or we expect that we have to give more energy, which means we expect patients to have more discomfort. Now, some patients would tell us that I still want to go ahead, I want to try, I have high pain threshold, we would go ahead and try. Now, again, during the procedure, you are fully awake, so at any point you want to stop the treatment, we could do that. On the other hand, there are patients who say, I have very low threshold for pain, I don't even want to try it. Then we can, talk about other options that are available for the treatment of tremor. And for all patients going through focused ultrasound treatment, they all undergo the same preoperative workup as any other surgical procedures. So again, on the day of procedure, it's outpatient. First thing we do is to shave the head. We put on the head frame, the same head frame that we use for focused ultrasound and DBS treatment. We do a wake testing, again, similar to DBS as well. Because the treatment is with the patient awake, there are some discomfort that they may feel. Pain, nausea, and giddiness are some of the most common ones. Post-operatively, the patients usually go home the same day. We give the patient some steroids treatment for the next 5 days or so. That is to treat the swelling that happens after the treatment. And at the same time, we tell patients to expect side effects. We tell all patients that after they go home, they may go home from the hospital feeling well, but over the next few days, they may start experiencing side effects. And again, these are the side effects such as tingling and numbness, gait imbalance, some speech difficulty or weakness, mild weakness, or incoordination that they may experience. So we usually tend to tell patients to be more aware after the treatment, take one step back, just make sure you are aware of your surroundings. And because we do that because some patients, they may not be expecting side effects after treatment because they are well on the first day. But we always tell patients that, we expect transient side effects that will come and then go away. So that's one reason why we tend to be more careful for patients who have baseline gait imbalance, because we don't want to tip them over during the recovery phase of the treatment. So at Penn, we've done a very high volume of focused ultrasound treatment. We are the first site in Pennsylvania to do this, started in 2017. Right, even before focused ultrasound was approved by the FDA, we have now done more than 550 cases. We are very interested in using the most advanced neuroimaging to help us with the planning, because we are almost obsessed at making sure that we are precise and we want to minimize side effects that patients have after this treatment. Because again, we know that there are side effects, there are transient side effects, but we take every effort to minimize this. And we are also very interested in using focused ultrasound in other indications, in exploring treating other indications. So how do we use advanced imaging for targeting? So this is some of the papers that were published by Dr. Halpern in his earlier days. So in this picture here is exactly where, in this cartoon, you can see this is the exact area that we know is involved in tremor control. We call this the VIM, nucleus of the thalamus. And on the right here is the high quality MRI that I've mentioned a few times that we use in targeting during the procedure. So we want to be as close to this area as possible and as precise as possible. So in the top right, you can see we use segmentations to try and identify this area as precisely as possible. And we've shared some of our techniques in how we do this with the community as well. So we also looked at whether our patients are satisfied with treatment after. You may receive a questionnaire after the treatment to share your experience so that we can improve the treatment for our subsequent patients. So you can see that most of the patients are very happy with the treatment. We ask them 3 questions. Are they satisfied? Did the treatment meet their expectations, and would they recommend the treatment to other people? And most of the patients express that they would recommend and they're satisfied with treatment. But we are also very interested in patients who are not. So we looked at why are patients not satisfied with treatment? And most of the time, there are two reasons if they are not satisfied. One is if they did not have sufficient improvement in the tremor, or the second reason is they have long-lasting side effects. So you can see here, this bar chart here means for patients who are not satisfied, their side effects that they experience early on and long-term, meaning after 6 months, it did not improve. Whereas patients who were satisfied, the side effects that they experienced were short-term. In the long term, they all went away. So again, that knowledge helps us guide our decision in recommendation treatment. So again, how do you choose between deep brain stimulation and focused ultrasound? So again, there's a lot of discussion with patients preference, whether they want, they mind having a full head shave, or do they, or is there something that they are very concerned about? Do they just want minimal shave? Is the invasiveness a concern for them? Is the ability to tune the treatment a concern for them? Because again, DBS, we can tune it, we can adjust the stimulation that's being delivered. Whereas for focused ultrasounds, once the treatment is done, we cannot tune it. We do know that of all the motor symptoms, tremor appears to respond best with focused ultrasound. So if patients have only tremor symptoms, this is referring to Parkinson's disease, because essential tremor, all patients have tremor. We know that we are able to treat tremor best with focused ultrasound. For patients who are looking to treat both sides at the same time, and focused ultrasound is not an option today, because again, we have to space out the two sides treatment for focused ultrasound. And again, because of the concern of side effects, baseline function of patients, one of the most important consideration we have. So if patients come in already with gait difficulty, we may recommend not to go ahead with focused ultrasound. But again, that's a discussion we have with all patients in clinic. So I will show one of to end off one of the videos that we have for our patients treated here at Penn. This is available on YouTube.
That's the tremor in my hand. I actually have, it's not so bad in my right hand. It's just mostly, it's all in my left hand. And then I can feel, I can try to stop it, but it just wants to keep going.
Jump ahead so you can see how the treatment is done.
Dyskinesias and stiffness and slowness associated with Parkinson's.
We are able to do this with a patient who is awake and comfortable in an MRI scanner with real-time imaging. The patient will feel relief immediately, and the patient will go home the same day.
Here's the head shape, and we put on the...
We can apply low levels of focused ultrasound to the thalamus, watch the temperature increase using the MRI technology that's called MRI thermometry. And as we apply these little bits of energy to the thalamus, we can see responses in the tremor. We're going to do our first ablation. And we track those responses by having the patient draw spirals or reach out and hold their hand out.
Can you bring your arm up for me? Bring your arm up. Show me that tremor. Now what we're going to do is create a lesion in the area we've been targeting by going above 55 degrees. So the orange lesion is our target, which we've planned. And you can see that white area around it is the lesion that we've actually created. So we're going to do our last ablation and then be done. All right, that looks very good. I'm happy with that result. How you feeling?
Much better.
Yeah. Yeah, you got it. Yeah. What do you think? Look at touch my finger here and touch your nose. Over here. I'd say that's pretty good for day one. I'm just gonna check your strength here. Squeeze my fingers, squeeze, squeeze, squeeze. Pull me towards you.
Good, super strong, excellent. All right, just relax. I'm glad that you're doing well. We were able to get you through this, okay?
Thanks, Doc.
You're very welcome.
The effects of focused ultrasound are quite durable. We have data out at 5 years. It shows that 80% of patients continue to have significant control of their tremor. While this therapy is... So all our treatment are currently done here at Pennsylvania Hospital, as mentioned. But we do see patients down at Lancaster, Dr. Cajigas, myself at Radnor. Dr. Halpern sees patients at Cherry Hill and Princeton as well. So we try to be more available for patients and see them wherever it's convenient for them. So I think, did I stop share?
Yes, thank you, Dr. Q. There are 2 questions here for you. Is whether someone lives alone and has caregiver support a consideration when choosing between DBS and focused ultrasound?
So, well, usually in the recovery phase, we encourage patients to have caregivers with them, especially, the first few days or first week or so after treatment, because we tell them, after all, they have a brain procedure, they need to be more careful. So especially, I would say for patients who are staying alone, we tend to tell them to arrange for somebody with them in the initial period during the recovery, whether it's focused ultrasound or deep brain stimulation.
And does the focused ultrasound help head or torso tremors, or mostly just hands?
So for head and vocal tremors, because it's a midline tremor, the traditional thinking is that for midline tremors, you need to treat both sides of the body. And as I mentioned earlier, for focused ultrasound, for now, we can only treat one side of the body at a time. We tend not to promise that the head tremor or vocal tremor will get better. In fact, we don't aim to improve the head or vocal tremor with focused ultrasound treatment. However, we have had patients come back to tell us that with one side treatment, it did improve. It does not eliminate the head or vocal tremor, but there's some improvement. But again, the traditional thinking is that for central or midline tremors, you need to treat both sides of the body. So deep brain stimulation might be better for that.
Great, thank you, Dr. Q. So next, we are going to discuss what to expect after surgery with nurse practitioner Denise Miller. Denise Miller graduated with her master's in nursing and adult geriatric nurse practitioner in 2014 from LaSalle University. She has been with the Department of Neurosurgery since 2008, first working in the operating rooms, Gamma Knife, then as a nurse practitioner since 2014. She has also had a cranial focus and about 2 years ago moved into movement disorders full-time. She enjoys meeting patients and their families and providing comprehensive care for before and after surgery.
Thank you, Gabby. Can everybody see my slides?
Yes.
Thank you. So I know that with presentations from Dr. Cajigas and Dr. Q talking about DBS and focused ultrasound, I'm going to try to highlight some of these things, but some of it has already been brought up. But thinking about that this is an elective procedure for treatment of tremor, we do need to make sure that we are taking care of everyone safely to have the best possible outcomes. And so we do have a standard battery of testing that we do before the procedure, looking at cognition and cognitive testing, the pre-procedure imaging, pre-procedure testing, blood work, EKG, and then also obtaining clearances from providers to make sure that it's safe to undergo anesthesia in the procedure. And sometimes we recommend therapy evaluations beforehand as well. So thinking about DBS, that is usually a staged fashion procedure. Stage 1, placing the leads. Surgery could take somewhere between 2 to 3 hours. Usually somewhere between 9 and 10 days later, we place that battery tunnel from the side. There's a small incision on the side of the head and then also on the chest to place the battery. And times we stage that into one lead at one time and then a second lead 3 to 6 months apart, sometimes depending on those cognitive testing before surgery. Thinking about getting ready for DBS surgery, typical preoperative restrictions for fluids and food. You get instructions on medications that need to be stopped safely. We also do try to minimize infection, kind of just using very mild skin products and shampoo. You would use these after surgery as well, just to minimize irritation of the healing incisions for usually 4 weeks to maximize the recovery of those incisions. We also use special pre-surgical wipes before stage 2 surgery to minimize any bacteria on the skin. So stage 1 day of surgery, just like Dr. Q and Dr. Cajigas had mentioned, all the surgeries take place at Pennsylvania Hospital location, either in the main hospital or our short procedure unit right next door. And so kind of just thinking about how you'd spend 1 night in the hospital for the first surgery, going home. That second surgery would be a day surgery. And then thinking about just how you would feel after surgery, because we're making incisions on the scalp, placing those leads. You could have mild pressure headache, some swelling, bruising kind of in the areas of where we put that frame on, very minimal. You could just feel tired from having the brain procedure for 4 to 6 weeks. Really does vary based on kind of what your energy level and kind of endurance level is at baseline going into surgery. There could be some cognition, memory, or some word finding changes short term. You can definitely see a honeymoon effect after the leads are placed temporarily until it is connected with those extension wires into the battery. You can see improvement in the tremor symptoms, which is great. So thinking about going home after surgery, we typically send you home with a short course of pain medication in case you need it, stool softeners so you're not straining to move your bowels after surgery, and sometimes antibiotics just to prevent infection. And usually you're evaluated at the hospital to determine kind of how you're doing after the surgery. That would potentially recommend home care services, which would include a home care nurse, PT, OT, maybe even some speech therapy. And we do recommend that you take showers every day, washing your incisions, kind of just keeping them clean and dry, stay hydrated. We recommend high protein diet, anything to help with increasing wound healing. We also talk about before surgery, making sure that if you're diabetic, that your hemoglobin A1C is well controlled. And you've talked to your provider to kind of maximize that recovery. And so for which everybody has kind of alluded to a little bit about after surgery, those activity restrictions, because we place those leads for the first 2 weeks, we don't want you bending that your head's lower level of your chest, pushing, pulling, lifting anything more than 5 to 10 pounds. We generally want you up and walking to kind of make sure, just kind of healing from surgery in general, that you don't develop a blood clot, taking nice deep breaths, up and moving around, and that usually about 3 to 4 weeks after surgery, and you can start to slowly increase your activities and resume kind of an exercise routine. But during this process, you're still working with home care PT, OT, and once you're released from them, we do recommend that kind of just proceeding with some outpatient therapy to kind of maximize your recovery. So thinking about just how we manage those incisions, usually there's a wound check where we evaluate the incisions, remove sutures, staples, about 8 to 14 days from surgery. That could be done by our office, could be done by the home care where you're staying at home, or with your primary care doctor. We usually see you over a video visit at 1 month, so we can kind of verify and see over video that the incisions are well healed. At that point, we would let you resume your normal skin and hair routine, and then also discuss if you've been released from home care, doing therapy, recommend doing outpatient therapy to maximize that recovery. And then usually seen back with the surgeon at a 4-month visit, just to check in, because you've been seen by your neurologist for programming in the meantime for a couple sessions. So programming initially 2 to 4 weeks after surgery. We often do turn that device on with the second surgery, and that you should pretty much take your programmer with you everywhere you go, just like they had indicated. If you needed an x-ray or you were seeing an orthopedic doctor for a condition, you could turn your device off, get that x-ray, and then get that completed while you're in that office. So other things to think about is that once you have DBS implanted, that possibly getting a medical alert bracelet to let everybody know that you do have the implanted device, carrying your DBS card with you. We do have special precautions for MRI. We do need to complete a form. Your neurologist who's been managing the device or our team can help with that. There are certain types of medical and surgical therapies that could damage the DBS. And so there are diathermy, lithotripsy to break up kidney stones, and transcranial magnetic therapy. And so normally we do recommend that the DBS device be turned off during most surgery procedures. And we also discussed scuba diving not below 33 feet, and that when traveling, going through airport security at the courthouse, that you should be hand searched, safe to walk through the things at the mall. And then usually for the short term after the procedure, for about 3 months, we recommend taking an antibiotic just before invasive procedures, dental work, things like that, just until your body gets used to having the system in place. But we don't recommend lifelong like they do with some of your orthopedic implants. So thinking about getting ready, and after HIFU, the high intensity focused ultrasound, again, takes place in the Spruce building, the short procedure unit at Pennsylvania Hospital. It is a long day till we kind of get ready for the procedure, do the procedure, do a post-operative MRI to verify that target that was created with image guidance, evaluation and recovery by a therapist to see if whether or not any home therapies are recommended. So as we've talked about, those expected side effects being that just fatigue, gait imbalance, speech changes, which could be some slurring, kind of weakness, numbness, coordination and dexterity changes, where you're thinking about kind of retraining your hand and movements that you've kind of compensated for a number of years, depending on how long you've had tremor, and thinking about trying to write and do some of those everyday activities, kind of relearning and retasking. So I know that Dr. Q had shown this as with patient responses on before and after, but we do get real-time evaluation and improvement in that tremor. So we also do prescribe, when we're thinking about the medications after DBS, medications that we use after focused ultrasound is a steroid medication, a little bit stronger than prednisone, which most people are familiar with, just for a few days, 4 to 5 days after the procedure. For the first week, we recommend limiting kind of some activity, no strenuous activity, no bending, just as that inflammation around that lesion that was created diminishes. And then the limitations after that first week are kind of dependent on those side effects from the treatment and how they're affecting your everyday activities. If you are having balance and walking issues, have some weakness, numbness, or dexterity coordination changes, that would impact maybe some of the activities that you're getting back to as quickly, and that making sure we're doing all of that recommended therapy that was recommended. So really thinking about maximizing outcomes, that we really do recommend thinking about those expected side effects, and they vary from patient to patient. We just like to make sure that we're very proactive in talking about that all of that could happen, but varies from patient to patient, and that really doing the therapy and maximizing that recovery, and which essentially after focused ultrasound, depending on how many weeks you're working with home care, and then start outpatient therapy for several weeks, it could could go from 2 to 12 weeks until you complete all of that therapy. And so thinking about how things are going once you're home and when to call our office, by all means, if you fall, hit your head, bump your head, have any changes in new or worsening confusion, worsening headache that aren't relieved with over-the-counter products, we usually recommend just using Tylenol. New or worsening weakness in your arms and legs, that would be in after that initial weakness, numbness that we see from the focused ultrasound procedure, something that significantly changes, getting worse, not better. We expect those to all get better over the next coming weeks. Any concern for infection, swelling, redness, warmth at your incision, any type of drainage, pain or redness, swelling in the legs, especially one, not both. We would be worried about blood clots. That's why we recommend everybody get up, move around. Any fever, temperature greater than 101.5, seizure activity, and then thinking about long-term living with DBS, that if at any point you have an opening, the skin over your device wears very thin, you fall, bump your head, hit your head on a cabinet in the kitchen coming up quickly, that if there's a scab or any open area at any time, our team would want to see you, evaluate that, because we would always be concerned about making sure that all of that is intact and that there isn't any risk for an infection because of that opening in the skin near the device. Stop sharing and see if anybody has questions. I know that we have just a few minutes to talk about questions.
There was a question about the neuropsych testing, if you need it for both DBS and ultrasound.
So we usually do a short cognitive evaluation called the MOCA in the office, and depending on how that scoring comes back, then there might be a time where we would recommend a formal neuropsychological evaluation, but many a times we can do that kind of an abbreviated cognitive testing in the office as a screening before both procedures.
And the other question was about does having pets increase infection risk to the incisions?
So thinking about having pets in your home, just that does not. I think it all depends on that. When we think about talking about caring for your incisions with focused ultrasound, they're just little pin spots that over 1 week later you can barely see that you even had that done. But thinking about permanently implanting a foreign device, the DBS, that during the day when you're towering once a day, the least amount of times that you touch at your incisions as we touch our environment the best, just to minimize risk for infection. I don't think having pets in your home at baseline increase the risk for infection, but I think we have to think about if your animals sleep in bed. I know that some patients say the cats kind of sleep kind of around their head in the bed. I think that you might need to kind of have them stay in a different room, kind of think about those things, just that making sure that doesn't increase the risk that that could possibly be a factor in the healing process. But overall, not usually.
Okay, any other questions from anyone before we go on to the next presentation? Okay, great. Thank you, Denise.
Thanks, Gabby.
So next, we are going to hear the benefits of physical therapy and staying active with Dr. Physical Therapy Jennifer Brown. So Dr. Jennifer Brown is a board-certified clinical specialist in geriatrics with a focus on Parkinson's disease inspired by personal family experiences. She founded Dynamic Home Therapy in 2011, offering in-home neurorehabilitation services, and later launched Dynamic NeuroFit in 2021, an outpatient neurorehabilitation and wellness practice in Berwyn, Pennsylvania, including 3 Rocksteady boxing locations for PD group fitness. Dr. Brown is certified in LSVT Big, PWR, which is Parkinson's Wellness Recovery, and Rocksteady Boxing. In 2024, she joined the Rocksteady headquarters, board of directors, and chairs the medical advisory committee. Initiated a Parkinson's support group in 2023 and completed the Parkinson's Foundation's Allied Team Training Program in 2021. Dr. Brown is a recognized speaker for ED events and has earned several awards, including the American Physical Therapy Association Pennsylvania Private Practice Special Interest Group Award, the Small Business Achievement Award, and the Best Physical Therapy Practice in Chester County in 2022 to 2023.
Thanks, Gabby. And of all days, my allergies are so bad, so forgive me if I have to take a sip of my Starbucks, which I had to have Grubhub order it during the talk. So no, this is really an exciting topic. And you guys were already asking a few questions, you know, when Dr. Feldman was talking a little bit about some of the options and treatments. So I'm excited to go over this with a lot of you. And we'll just be talking about the role of exercise. And then it's PT and OT really, because there is a lot of upper extremity involvement in fine motor coordination. So, you know, as we talked about already, there is involuntary movement and tremor with ET in the hands, but a lot of times too, with some of our clients, we might see it in their head, in their voice and other body parts, which can affect more than just fine motor coordination, as some of you may know who are experiencing it. We know that exercise is medicine, and we also know that a lot of people that we see with ET will have worse tremors after they exercise or when they're fatigued. So then some of our clients will not want to exercise, or the question is, should I be? So we know that the tremor will get a little bit worse after, but then it usually calms down. We also know, as we've heard, that, you know, if you're stressed or anxious, or if you're rushing or you didn't sleep great, that can also make it worse, right? So I always think of the person who is rushing to get to therapy or a doctor's appointment and they didn't sleep great. And then by the time they get there, their tremor might be really worse. So there's a lot of information out there on the web and just in general that yoga, mindfulness, meditation can be very, very helpful in helping to decrease some of those from a physical standpoint that we can help you with. And as Dr. Feldman said, there's no great research that we've found for exercise specific to ET, like there is for Parkinson's. So it's a little tricky. But we do know that exercise helps to improve quality of life because there is a lot of anxiety and depression that can come also. So we do follow, as therapists, the American College of Sports Med, and this is in general exercise recommendations for people. So we follow the same thing, whether it's Parkinson's or ET. So thinking about 150 minutes of cardiac exercise or cardio aerobic exercise per week. And I will have people think that that is so long, but out of the whole week, it's 2.5 hours out of your week. And you can split it up throughout the week. They're not saying all in one day. In fact, it's better to spread it out. And they are recommending moderate intensity, which unfortunately, a lot of my clients ask if that counts walking to the mailbox or taking their dog out, and it does not. So it has to get you working where you feel like you're working, right? You can still talk, but maybe you're breathing a little bit heavier. And it just gives some examples, you know, so if you're really cleaning and getting your heart rate up, if you're doing gardening, if you're going for a brisk walk around the neighborhood, certain yoga. Now, if you're doing more of a relaxation yoga for the anxiety piece, that's a little different than a more intense flow yoga where you're getting your heart rate up. Also, the other option is vigorous, 75 minutes if you're not doing moderate. But again, any is better than none. So with the vigorous, you're having trouble. So you might be walking up a hill or hiking or doing things that are really getting your heart rate up where it is more challenging to breathe. With all of these though, you wouldn't just run out and do this, right? Because some of us out there may have cardiac history, right? So doing that initial evaluation first with a therapist is really, really critical because we will assess your vitals, we go over your medical history, and it really is more individualized versus just saying, go do all of this, okay? Plus, you might have other issues going on. The other recommendation is for strength training. So resistance training for all the major muscle groups, 2 or more days a week but with a day in between at least, right? So a lot of times you might be doing a cardio workout that's including, you know, light dumbbells, something like that. So it can be body weight, it can be the bands as you see. The person in the middle is also working on balance by sitting on the ball, so that's extra bonus points. But these are things that we can help you with, or if you take exercise classes at a gym, they might be covering more than one area at a time. And then the last recommendation is flexibility and neuromotor exercise, which is balance. So thinking about if you are taking a yoga class, you know, and this is 2 to 3 times per week. Now, a lot of people get worried and they think, well, if I'm doing weights twice a week and this 2 to 3 times a week, and then the cardio, it's going to be every day and there's not going to be any downtime. So it can be combined. And a lot of exercises are multimodal, which means we combine them. So you're working on more than one thing at the same time. But it really, really is helpful. And even though potentially tremor might just be in your hands, maybe then you're not moving as much. Maybe the balance is also a little bit off. You know, so there's a lot of different areas that we want to look at and assess and work with you on. And to get you on a program, because you may not know what that looks like for you. The other part that we look at is just as if we're talking here with the movement disorder specialist and the neurosurgeons and the neurologists that see more of the essential tremor and Parkinson's types of diagnoses, there are certain therapists that also specialize more in these areas versus a general therapist. Ideally, that would be your best bet because they see more people with these diagnoses. But as therapists, you know, we would assess areas that are challenging to you because they may not be challenging to the next person. Making recommendations for any adaptive equipment or maybe modifications or techniques that we have to train you or teach you in, setting up that program. Like we said, it can't be a cookie cutter. It's very individualized. And then looking at other issues, right? A lot of people, we have as we get older, orthopedic issues, there might be osteopenia or osteoporosis, cardiovascular. And with the tremor, we see a lot of clients with hands who are aging where there might also be arthritis that can be adding to some issues with their hand control. So there's a lot of things that we're looking at with that too. And then just as we said, balance, walking, mobility, the sleep hygiene is something that is covered under occupational therapy. Through their plan of care, that a lot of our OTs will work with clients on how to sleep better, get more into a routine, help with that relaxation piece so that you're feeling better the next day. And then again, like leisure activities, what do you like to do? What are you not doing maybe because you might be embarrassed to go out in the public, or a lot of our folks don't want to go to parties or restaurants because eating might be challenging with their tremor. So really thinking about things we can help improve the quality of life. And then again, just as was said in the last few talks, we work closely with the team for people either pre or post DBS or the focus ultrasound. If there's not a nurse needed, we'll usually go out to see the folks who are getting the focus ultrasound within that 24 hours, just to, you know, if we have to make any changes or for safety those first couple days too. But again, working with your doctors and the surgeons. Okay. And then addressing the challenges with ADLs and IADL. So this is really more to give you an idea of just some things. Again, this isn't for everyone because everyone may have different issues, but fine motor coordination. And again, it's not necessarily that the hands are getting weaker. The coordination is off from the tremor. So the further your arm is away from your body, the worse the tremor will get. So a lot of the tricks that we teach are keeping your arms closer to your body or your body closer to the table or where you might be working if that's an issue. But handwriting, you know, there's weighted pens, there's the cuff Velcro weights around the wrist, leaning on the table, writing smaller versus really bigger can help because it keeps the tremor at bay sometimes. With dressing, there's a lot of companies out there now, and on Amazon, if you look, the magnetic clothing, the magnetic closures, they are really nice and they look just as regular clothes. You would never know. So instead of having to work the buttons or zippers, things like that, some of the new sneakers out there, a lot of our clients use the Cajigas, where you just slip your foot in. You don't have to worry about pulling the back up. Some of them, then you don't even have to tie the laces. It just makes life a little bit easier. On the computer, that seems to be a big issue too for our clients. So there's different mouses, there's speech recognition. In your accessibility features, you can set that up, and OT works on all of this with you. Same with the phones. A lot of the phones now, which is really nice, you know, on the cell phone, you can talk to text, you can record yourself giving a note. There's larger phones. If you still have a landline phone, they have ones with much larger buttons, so they're easier to work. And a lot of people wear, you know, the Bluetooth speakers in their ears, the AirPods, things like that. So you don't have to worry about touching the phone and working things during the conversations. The other thing I just put here is the SteadyWear glove, and I'm not sure if you guys are familiar with it. We have a couple of trials that we use with clients. It's a glove, it's weighted, there's a magnet, and it's supposed to counterbalance some of the tremor when you're working. For some of our clients, it works really well. For some of them, it doesn't. It's not covered under insurance. If you're through the VA, there's sometimes coverage. And the one thing is that for some people, they'd rather have the tremor than wear this big bulky thing on their hands when they're out. But if you're home and it helps, that's definitely one option. Jewelry, makeup, there are magnetic attachments on Amazon for necklaces, for earrings, to make life easier. Cutting the food, and you'll see on the right for eating and cutting, that seems to be a big area. There are, as many of you may have tried, weighted utensils or those foam things on the right that you can see that you can build up things that you're working on. So it's a bigger grip. As far as eating goes, you know, plastic is better than glass, obviously, if possible. But there's also built up bowls and plates that have an edge around it so that if you're eating and you're starting to have more tremor, it won't push the food off your plate. There's so many things out there, and that's where OT can really play a role, because they know all of the different types of equipment and they can trial it with you. We tell people, never waste your money if you don't have to. Make sure it's going to work for you first. And then on the bottom right, you'll see that spoon. It's the liftware utensil. And if anyone has tried that, it's on Amazon also. It's about $200 for the starter spoon. But when you start to move, it offsets the tremor so that it holds the spoon a little bit more steadier, so it won't shake as much. For shaving, brushing teeth, electric is much better for both. There's little tricks, you know, putting your toothpaste on the counter and then just using your hand to squeeze it onto the toothbrush. So lots of little tricks that you can do that you can work on. And that's why a lot of times OT might be better in the home. You don't have to be homebound. There's different types of insurance coverage, so that's something to consider also. But these are other little things that you may work on. That test on the left, some of you may have taken, it's the 9-hole peg test, and we will do that a lot to get a baseline and then work on coordination. You have to put the pegs in the holes, looking at both hands. And then these are just some of the toys that we use that we might work with you or have you do as a home program to fine tune some of the coordination, and some of you that might need the strength training with it. And then on the right, I put that there. That is a U-step walker. So for some people that we see with tremor who are having a lot of balance issues, if you use a regular walker, you know, it could shake side to side and be really unsteady and maybe a higher fall risk. The U-step walker is used for people with neurological conditions, but it's really steady. It's a steady frame. It's really hard to tip over. And it is covered under insurance if you don't have another device in the past 5 years. So that's something that we trial at our clinic with a lot of folks. We could take it to the home and see, but it's just another piece out there that's a little bit safer, but it's really tricky to manage taking out in the community because it's so heavy and it is a flat frame. It doesn't fold up like a regular walker. So just things to consider. And then the other thing is thinking about group functional fitness, right? So for some folks, like I know like myself, if I were to sit home, I would never work out, even though I'm a PT. I need some kind of motivation. So being out and about, going to a group class, you socialize, you're practicing different moves. You're practicing a lot of floor activity also for some of the classes, which is really important if balance is an issue. Also, just the music, it helps with anxiety, feeling better, you're laughing, and being around people is always more motivating because you're going to push yourself harder, right? So for some tips and takeaways with this, obviously you would check with your doctor before starting to exercise if it's new to you. In most cases, if you're doing therapy, we would ask that you're going to get a prescription for PT or OT. Generally, we're going to go through a neurologist if we're seeing someone for the essential tremor. And again, trying to find someone that has some experience in movement disorder. It is tricky because if you call any of the local places, they might say, oh yeah, we've worked with someone, but you can ask like how often, right? Maybe it's one person a year, two people a year versus someone that's seeing that on a daily basis. There is for those of you that know or have heard of LSVT Big, that's a program specific for Parkinson's and movement disorders, but they do have a national website, and most of those therapists who are on there have more experience than others. And finding something that you're going to like, right? So if you're someone that needs a group, find a friend that will walk with you, find someone else who might be motivating, and make sure it's something that you like. I had a patient that hated yoga, but yet she went because everyone was telling her it would be good for her anxiety, but she hated it. So, we have to find something that she would like to do, and it ends up that she really enjoyed gardening more, and it brought her joy to be outside. So just kind of thinking about that. And then the parts of the exercise program that we're looking at. The other thing I always throw in there is if you are doing a new type of exercise or a new skill, that has added benefits. I heard, a couple of people asked about dementia, things like that. As we get older, the brain can do amazing things, as many of you have probably heard of neuroplasticity. So we're always trying to add a dual tasking or something that's going to work the brain with the body. That's always more beneficial. But first, we just need to get your body to move. And since the pandemic, there are a lot more of opportunities for exercise, not just in person, but also virtually. So again, it depends on what you need to motivate you and how you respond, but there are a lot of options out there. So again, working with your whole team, advocating for yourself, and your doctor may not even be ordering therapy, or if you're going to your primary care and you've had essential tremor for years, we see a lot of people that say, oh, I had therapy like 15 years ago and nothing really changed. Well, in 15 years, it may have changed that maybe you have new symptoms. So you need to be reassessed. You need a tune-up. And some people will get a tune-up, like once a year, where insurance will pay for that evaluation to relook at your program, modify things, see if anything has changed, and then just really trying to stay active as best as you can. And that is it. If anyone has any questions.
It looks like someone had mentioned that desk ellipticals were really great for working with balance and safe, but get some sweating.
An elliptical?
Yeah, the desk ellipticals.
Oh, yeah. Hey, if that's going to work for you. Now, the ellipticals that you're standing at and working your arms and getting more, obviously, that'll get you up cardio more. But absolutely, there's one called the QB. I think it's CUBI. And we use those a lot with folks at home so that it just gives you something to work on and move. It's better than doing nothing. And if that's what you're going to do, we love it.
Is physical therapy covered by insurance, particularly
Yes.
Medicare, AARP, if you know?
Yes. So Medicare, so it depends. And this is where you kind of have to advocate and You know, and if you're working or talking to Denise, she can help too when she's ordering it. If you need a nurse and you're homebound, meaning it's really challenging to get out of the house, then that is under Medicare Part A. And that is covered, but that means there's therapy and a nurse, sometimes a social worker, sometimes an aide a couple times a week if needed, if it was post-surgery. Medicare Part B is your outpatient, right? So that's what pays to see one of your neurologist if you go to the office, or blood work, or outpatient physical or occupational or speech therapy. Medicare covers the first 80% if it's Part B. And if you have a secondary insurance, usually that covers the other 20%. AARP does. But be aware, if you have a Medicare Advantage plan, they don't have the same rules as Medicare sometimes, even though they may say that they do. So you might be limited or capitated somewhere that you can go, and you may have more out of pocket depending. But with Medicare Part B, you don't have to be homebound, but you can get it in a clinic if you live in an assisted living, or if you are at home. So it's outpatient at home. And that's what our model was initially. So it's definitely available. People don't know about it. And people think that they have to have something major happen to them to qualify for therapy, like a fall. So we want to see you before the fall so we can help guide you, right? And prevent that. But generally it is speaking to your doctor to get the prescription and going from there.
Andrea put, for anyone who may not have seen them, she put a couple links in the chat for assistive devices, and it looks like lending libraries where you could try out the devices before you buy them, just in case if anyone's interested. There was one other question. Someone had said they just completed physical therapy and their essential tremor increased with upper extremity strengthening. Any suggestions?
So I haven't heard of it increasing with the strengthening. I'm wondering if it's increasing on the days of therapy or if you're working too hard. Sometimes what we'll say is to kind of spread it out, right? So if you know that you're going to therapy, or if you have something big that day, don't overdo it right before. Kind of save your energy, and energy conservation is what the OTs will call it, and spreading out and helping you with a routine or your schedule during the day. Generally speaking, what we see is it can get worse right after the exercise, just because your heart rate's up, you're working harder, it can increase, but then usually it dissipates, you know, soon after they're home or done. I haven't heard of it getting worse over time just from strengthening.
Okay, I think that was all the questions here in the chat. Thank you, Dr. Brown.
Thank you.
So next we are going to hear from our patient panel. So there's a few patients that joined today that are going to share their experiences after advanced treatment for tremor. And that is going to be led by Dr. Pratik Talati. So Dr. Pratik Talati graduated from Vanderbilt University with his MD and PhD in neuroscience. He completed his neurosurgery residency at the Massachusetts General Hospital and is currently pursuing a functional neurosurgery fellowship with Dr. Casey Halpern at the University of Pennsylvania. He is interested in using neuroimaging methods and technology to help patients with neurological and psychiatric diseases.
Gabby, thank you so much for the kind introduction. I'm very excited about this patient panel. I think we have a wide variety of patients who are who have gotten both DBS and focused ultrasound. And I'm very curious to hear from a lot of these patients about what was their journey like, first with the medications that we talked about earlier, how they decided on the type of therapy, what their recovery was like, as well as wishing that maybe gotten the treatment sooner or seen a provider sooner to help with that. I'm
going to help direct traffic. So
okay,
Dr.
thank you.
Talati, let me know when you want me to unmute people, or I can just unmute everyone and let you direct traffic. What do you prefer?
I think it'd be great if you were to help direct traffic.
Yeah, Yeah. So we have Rob, Adrian, and Piet joining us to talk about DBS, and Bobby and George to talk about focused ultrasound. So who would you like me to start with? The DBS side or the focused ultrasound?
So I think since we have 3 from the DBS side and 2 from the focused ultrasound, maybe we'll just alternate if that's okay. So maybe DBS, focused ultrasound, DBS, focused ultrasound, DBS. So maybe we could start with, I don't know, Adrian.
Okay. You're
Do you
up.
want me to put someone on the spot?
Yes. You have beautiful artwork behind you.
Oh, thanks. Hi, everyone. I thought about this for years, and the neurologist that I originally was seeing kept telling me about DBS, and I kept putting it off and putting it off, and he wanted me to go down to Penn to talk to the neurologists that were down there. It was not Dr. Halpern at the time, but I kept saying no, no, no. And the one reason was, well, I kept hearing was you had to shave your head. That was the one thing that stuck in my mind. I know DBS is not, you know, shaving your entire head, but all I kept hearing is I had to shave part of my head. And as you could tell, I have long hair. And I was afraid. I was afraid until it got to the point, and I've had the tremors for many, many years. I would say, looking back, going on 25 to 30 years. And I was afraid. And it got to the point where I have grandchildren. My oldest one is 10. And I remember trying to hold the babies and shaking. And that's what led me to do it. And it is the best thing that I ever did. And I came home from doing it, and my husband called me into our office and said, sign your name. I thought, oh, what's he having me sign? And I signed my name on a Post-it, and he took the Post-it and he put it up to a card. This was in March. Put it up to a card that I had sent him for Valentine's Day, that my signature was all scratchy. And the difference of my handwriting, and I was a school teacher at one time, and my handwriting at that time was, you know, kind of immaculate. And the difference was incredible just from them turning on the DBS. And from that point forward, I was the happiest person in the world. I have tried all those tools that Dr. Brown suggested, the weighted silverware, which I wouldn't go out to eat with people because I was embarrassed to eat with utensils, you know, all those things. And anybody that I talk to that, you know, they have these problems, I suggested go see Dr. Halpern, go see Dr. Cajigas, because I had another stimulator in my body for another problem, and they had to redo that one to be MRI compatible. So I have 2, and I charge once a week, and I'm good to go. So anybody that listening, do it.
It's great to see that you've had such a great experience and an outcome with this. I know that there's sometimes a lot of hesitation about even that initial visit and seeing a provider, kind of a little bit of uncertainty. And I'm hoping that at least a lot of this education that we're doing now will help help people, and some of the stories that you've shared, and your anecdotes about your hesitation and eventually how you've had such a great outcome, especially for your grandkids.
And anybody that, wants to reach out, it's a lifesaver. And anybody that wants to reach out, I am always willing to be an advocate.
Great. Well, thank you so much for sharing your story. Are there any questions from the audience? Maybe you can do a hands up, or I don't know if we're unmuting or. All right, so I think we can maybe transition to another person, and
Dr.
the focus
Talati, just to chime in on Ms. Jaffe, it really is amazing seeing her doing so well. I think if a doctor like Dr. Feldman were to see her right now, she might not diagnose her with essential tremor. She looked really great. So thank you for doing this, Ms. Jaffe. Go ahead, Pratik.
All right, so now we'll transition to someone who's had the focused ultrasound treatment that Dr. Q had talked about. So maybe we'll start with Mr. Kraus.
Excellent. Can you hear me?
Yes.
Good. Well, three admin notes for those that don't have a alphabet after their last name here. But number one, for those that are attending, kudos to you. You're being very active participants in your management and treatment versus passive recipients. So spending time learning what are the options available, tremendous. For me, I found it to be very empowering, especially with my diagnosis, young onset Parkinson's at age 42, with a disease with no known cure. It put me in a position of controlling what I can control. So kudos for joining the call. Number two, just remember November is Caregivers Appreciation Month. I know for myself, my wife, when we said for better or worse, she didn't imagine 15 years later that it would be a Parkinson's diagnosis, but she's there helping me day in and day out and supporting me, and so is my family and my extended friends and caregiving network. Number three is because of the success I did have with the procedure and with Dr. Halpern and Dr. Willis and my team at Penn, I've actually recently left the corporate world, and I actually started a foundation called the Be Still Foundation, which is designed and intended to provide the financial resources for anybody who wants focused ultrasound but can't afford it or don't have the necessary medical coverage. And for Adrian and people that have those concerns, we'll cover hotel, accommodations, travel, wigs, whatever it may be, whatever is going to be that limiting factor from preventing you financially from going forward with a decision. We want to be there to provide those financial resources to pay it forward. I was very grateful to have an employer who paid out of pocket in addition to some assistance with Penn for me to have the procedure. And again, July 9th of 2022 was a life-changing day for me. So those are kind of the admin comments I had, but just at a high level, my experience. Again, I was diagnosed at 42 with young onset Parkinson's, being tremor dominant on the left-hand side. So from what I understand, I was one of the ideal candidates for focused ultrasound, although we did look at and explore the conversation of treating my symptoms with medication as well as DBS. For me, medication was actually worse than the Parkinson's disease diagnosis. Battled extreme depression, night terrors, cramping, anxiety issues. I was the father of 2 teenage boys, which adds its own element of stress and angst. And we all know what stress and angst does to tremors. So at times my son would call me Thumper from the movie Bambi because my tremors both in my arm and my leg would be going so rapidly. And then as their basketball coach, it was at an all-time high and all-time extreme anxiety level dealing with coaching them. So what ultimately happened for me was the medication was worse than the disease itself. The catalyst for me was my son's 12-year birthday party. I came around the corner and my son was apologizing to his friends about the way dad was acting. He's on medication and he has Parkinson's. So I immediately went in the house, flushed all my medication down. I texted Dr. Willis and said, we got to look for a different course. Came down to Penn. She introduced me to Dr. Halpern. We sat down as a family and we talked through what are the options, knowing the medication was no longer an option for me. So what we looked at then DBS versus focused ultrasound. And for me, again, at the time at 42, going into this diagnosis, I was trying to identify what was going to allow me to get back to my normal pre-Parkinson's lifestyle quicker, whether that's coaching, whether that's speaking at an executive engagement, whether that's coaching, whatever it may be. I wanted to get back to that pre-Parkinson's diagnosis as quickly as possible with as limited downtime. So one of the things I've learned through this process from Dr. Halpern and team is that for me, again, this and I agree, somebody mentioned it earlier, this is a very personal decision. Very important to have your family, your caregivers, and your medical team involved in this decision to identify what is the best course of action. But we looked at DBS first, and for me, at the time being, when I actually went through the process at 46 and was I wasn't keen on being out of work for an extended period of time. I wasn't keen on the incision aspect of it, but was very aware that if focused ultrasound didn't work for me, I could go to DBS at a later point to again really treat the symptoms that I had. So for me, we kind of fell back to the focused ultrasound was one where in and out procedure, no incision, really good results in impacting those with Parkinson, young onset Parkinson's that are tremor dominant. And again, the ability to have the procedure on Thursday, be home that night, go for a walk and a hike with my sons, and back into work on a limited basis that next week was very appealing to me in the process. Again, knowing that down the road I could go the DBS route if I so chose. As far as the experience itself, for those that have met me, I'm 6'6", a little over 300 pounds. So being inside that MRI tube for an extended period of time isn't an ideal situation, but hearing Dr. Halpern kind of talk in my ear and over the loudness of the machine at times was very calming and soothing. The staff was incredible. They do a tremendous job of preparing you for what to expect. Again, that morning it is a little unnerving, just knowing that there's going to be you think of an ablation in the brain. But I can tell you this, other than marriage, my 2 children's in my faith decision, being in that tube and actually watching, physically and visibly watching your tremors go away was the most amazing experience that I've ever gone through. Looking down the tube and seeing my toes unfurl and release from the dystonia and some of the rigidity and stiffness, feeling my body conform to the circularity of the MRI tube. It's just something, I just sat in that tube and just sobbed uncontrollably, just knowing that my life had changed. And I was able to experience and watch and see that in real time. So those experiences, that ability for me now to be able to coach my sons again, to have that time in the car with my sons, not to be embarrassed, not as now a 50-year-old man feeling like I was broken, being ashamed. The depression is mitigated. I'm going back out to eat with friends and family. I'm engaged in social events. I've had the privilege to speak at Congress about my Parkinson's journey. I've had opportunities like this to share my story as well. So for me, it was a tremendous opportunity to improve my quality of life. There's other things with the Parkinson's that I have. It's not a panacea for Parkinson's, obviously, but for the tremor component of it, this was a great solution and option for me. And again, if there's anything that I can do, you can reach me at Bobby at Be Still Foundation. But I appreciate the time to share my story. And thank you again, Dr. Halpern and the Penn team for all that you did to significantly impact for the better my life and my family's lives going forward through this tremor mitigation.
Hey, Bobby.
There he is.
Thanks for being with us today. I can say with certainty that while it's been such a privilege to help you, you've helped so many people by sharing your experience and making them feel comfortable doing this, because it takes a lot of courage to do it. And it's understandable why people might be scared, but your advocacy for the therapy and for people with Parkinson's and tremor, just wanted to thank you for everything you're doing. It's a really tremendous thing. This piece of information has huge impact potential, and appreciate you leading the way on that.
Are there any questions for Bobby? Okay. All right. I think next we'll love to hear from Rob.
Hello, everybody. I'm a physician, and my path, my course is a little bit different. It was one going way back to residency and deciding which direction within the surgical field I was going to go. And I had to choose something where the essential tremor that I experienced would not get in the way of my surgical experience. I'm a urologist and I specialize in endourology, which means that I use predominantly a robot and scopes that don't require a tremor. Fine motor skills and doing microsurgery has always been very, very difficult for me. And my greatest fear when I was on call was that GYN or general surgery would call me into a room to fix a bladder and I wouldn't be able to do it. I always kept the beta blocker in my locker so emergently I could take something if I needed to. The tremor got progressively worse and was starting to interfere not just professionally, but in my private life doing fly fishing and shooting sporting clays. I wanted to be able to put little tiny flies on a fly line. You just can't do that if you have a tremor. So I needed help. Now, I've been very closely associated with Boston Scientific through my entire career. And I had the luxury of looking at the professionals that were doing this kind of procedure across the country and choose my team based on inside information, not just outside information, what's in the press and if you were to Google. I sought out Casey Halpern. I was very impressed with what he was doing. I'm a Jefferson urologist, so it was very hard to transfer to University of Pennsylvania, but you got to go where the best is, and the best is at Penn in this situation. And between Casey and Jamie and everybody that I work with at Penn, the results have been outstanding. If I put the device on, you can do a simple thing like pick up a martini glass and not spill it all over the table. I think that was the biggest immediate finding that I ever saw, that holding things was not an issue. I became ambidextrous and I can actually write with both hands because my left hand, which was always my dominant hand, was becoming incapacitated to the point I couldn't write my name. And I used to sign all the drug reps papers with my right hand, and nobody ever knew the signature difference. So the course has been outstanding. The results have been far beyond what I ever dreamed, and I don't shake. And that's the bottom line. And the stimulator is on. It's on right now, and I'm rock steady. So without that stimulator on, I wouldn't be holding this phone steady. I wouldn't be talking to you without some type of tremor in my voice. And it's a shame that it's happening just before I retire, but I'm a better surgeon as a result.
Hey, Dr. Barsky.
Hi, Casey.
I'm glad you did so well. Thanks for joining us today.
No problem. I've sent you a lot of patients. I think my office hours have become more neuro and neurourology than it is just urology.
Well, I appreciate you very much. And thank you for sharing your experience with everybody today as well, and saying such kind words. And you're a great advocate for the therapy. So thank you.
Sure.
Thank you so much, Dr. Barsky. I did have a question for you. Did you end up deciding whether to go with a rechargeable or not rechargeable system, and how did you come to that decision? Just for the audience.
I have a Boston Scientific device. I charge it probably too often. I charge it every day, but I could charge it once a week. I leave the charger at my Cherry Hill house. I'm down the shore right now, and I don't take the charger with me. I find I sleep better at night if I turn the device off, but at the same time, the charging is a non-issue. It's very easy to charge. It's very easy to control. The settings, you have to get used to it. And the one thing I could tell everybody is never turn the device on if you're driving, because the surge that you get is pretty outstanding. And you don't want to experience that behind the wheel. So don't do it when driving. I've made that mistake once, and it will never happen again.
Thank you for the tip.
Very practical insight.
Very practical. So next we'll shift gears and talk to George for his experience about the focused ultrasound.
Georgie.
Hey, hi Casey.
There he is.
I'm George Erickson, and my story goes that I was working till I retired as a training and development professional, and I found that my handwriting on flip charts and my ability to hold a laser printer or to be in a business situation having coffee or otherwise was getting more and more difficult. And I would have to explain it to people that I wasn't getting nervous, but just that it was something biological. And there were some head tilts and wondering, what was it like? But it began to interfere with my my life on a day-to-day basis. And I went to a neurologist to rule out Parkinson's. We had no history in the family. He started me on Inderall, and that gave some benefit for a while, but at a certain point, it wasn't. And I can recall being out on a date with a wonderful person who's sitting over here, and it was our first date, and I love Italian wedding suit. And here I am on my first date wearing it on my shirt. It wasn't impressive, but it was a motivating moment. So then a family member mentioned seeing focused ultrasound as a possible thing to help me. And by this point, the family was thinking of me as the martini shaker. So it wasn't a good time to sit still and not look into this. So I went down to see Dr. Halpern, and we had a great visit discussing the advantages of HIFU versus deep brain stimulation. And for me, after thinking about it for a couple of days, I decided that the focused ultrasound was the thing I wanted to do. And I've actually had both sides done, my right and left. I started with my right because that's my dominant one, where I did handwriting and I needed it to be worked on, for lots of tasks. And then that in October of 2021, I had my right side done, and you can see, Casey, it's still rock solid. Thank you very much. And in early 2023, I would have to say somewhere in the winter, I had the left side done. And it doesn't necessarily show on this Zoom meeting, but it's a little bit less. And that goes to the collaboration with the entire team. Dr. Halpern and I talked about, would I get as much benefit from the second procedure? And at what point would I stop? And what I said was, we'll go slower this time. And at the point in which I'm in the MRI and doing it, I started having a little bit of trouble with the limericks and the handwriting. And about 75 or 80% of what I had done on the first side, we collaboratively decided to stop. So I have a slight tremor on the right, but by and large, it's just made an incredible difference in my life. And what I found afterwards is that I needed physical therapy and speech therapy. I was a little clumsy in walking. Initially, Joanne could tell you, I was a little bit looking like I'd had a couple of drinks, but that the PT was a neuro PT focused individual, and she helped me understand that my core strength was an important part of not only balance and walking, but also in fine motor coordination. And while there was some motor work done, the combination was the right solution for me. And I made a couple notes to try and be brief, as some people might know I have trouble doing. Two things I would want to add at the end here. So going through the process of looking at medication and then, making the decision as to will I get looking at this type of thing, and then picking the procedure in collaboration with the medical team, and going through it and getting this life-changing benefit. At the point at which I had the first procedure, I couldn't hold a cup of coffee steady without wearing it, or it affected my love life, that kind of thing. And so I went forward with it. The thing I would say to people who look at this, you're going to find yourself becoming, like Bobby, an advocate for it. And people will talk to me who have known me with the tremor, and I will describe it to them and show my change with my hands, and they'll be impressed. And what I do is I tell them, if you got somebody in your family, have a conversation with them. And I was at the dentist office, for instance, and one of the hygienists talked about how her husband wasn't sure what to do. And Casey, he came down to see you and you spiffed him up, and she was very happy that I had advocated it to her. So the idea of advocating, like Bobby's talking about, is a really good idea. And I know I said two things, but if you know me, it never is. But the last thing, and I promise it is that I want to thank the team, Casey, the Inside Tech folks that worked with you that day, your radiation team, even the team that shaved my head and put that cradle on my head. They were caring and attentive and highly skilled. So it made a big difference in what I had done. And I was really glad that I've done this. It's been life-changing. So if you have any questions, I'm here. You can contact me through any of the folks running this. I briefly started working with Bobby and look forward to continuing that, because this is not something people know about. And as time goes on, they'll start realizing Parkinson's is important in dealing with it and gets a lot of attention. But tremor is a very real thing, like was said earlier, 10 times more frequent. And there is a very good solution for it, actually two, but I'm a big fan of the I call it HIFU. And so thank you to that team. I'm available for questions now or later. So that's what I wanted to share.
Thank you, Georgie. We're grateful to you.
He's one of the few people allowed to call me that.
I don't know what it is. You're more of a Georgie than a George to me. But I can tell you, the experience you've had with it, we've done now almost 600 of these at Penn. And every time it works, it really just feels so incredible, like a miracle, because we can do things without making an incision. The head shave is hard for some people, by the way. We have to go to the barber shop, like you pointed out. It's not easy for some people to accept that. I mentioned in the chat with deep brain stimulation, we've had people get deep brain stimulation to avoid having to get a head shave. I think that's okay. You got to sort of accommodate people as they need. These are both great options. And Georgia, you're having a fabulous outcome from Focus Ultrasound. I'm very happy for you.
I've been very enthusiastic at advocating for it. And I tell them to go to Penn. Dr. Barsky, Jeff's great. I've used them for other things, including orthopedics, but this team at Penn is the bomb, is the leader.
We're not on an airplane. You can say bomb on a webinar. It's okay.
George, there was a question from the chat, just kind of getting your experience about what it feels like to be in that MRI tube, and were you claustrophobic?
I looked Yeah, it is claustrophobic and noisy. And the team does a good job of getting you comfortable and explaining what's going to happen. And you're in and out of it, not in terms of speed, but you're in it for a while, the procedure, and you're coming out to do the test, and that helps with it. But I knew that this was worth doing. It was intrusive enough in my life that I wanted to do this. And keeping the goal in mind, it helped overcome the being in the tube. And you're only in from your shoulders or so up. So that helped too.
Right, and as you pointed out, we have an anesthesia team that's there too to help with a little bit if there's a little bit of discomfort as well.
And you know what? I got a little bit nauseous and an IV line in. They were able to give me an anti-nausea drug called Zofran. It's very well tolerated, and that helped right away with it. And in terms of headaches, Tylenol took good care of me pretty quickly. And my hair grew back actually more than it is now. So fairly quickly.
Great. And I wanted to make sure we had enough time to have our last panelist here, Piet, talk about his experience with DBS.
Afternoon, folks. First off, I'm in agreement with Mr. Erickson. Huge kudos to the entire Penn team, and especially Dr. Halpern and Dr. Hammer. Terrific job they did. Very patient. Great team. Second thing I'd like to say is number 5. How can I possibly, supersede what my predecessors just put out? So I'm going to do my best here to give you a little bit of my background. So in my teens and 20s, my background's in aviation, whether it's actually flying aircraft or doing maintenance on them. And unfortunately, this requires some pretty fine motor skills. So early on, I could tell that there was some degree of deficiency there, and I always chalked it up to nerves on my part. And it was kind of reinforced because I'd been in the military and kind of high stress environments. So some time goes by, and I thought that was just one of those quirks. At a certain point, I came to find out that my uncle and his daughter, my cousin, actually have essential tremor, and it was pretty simple to kind of connect the dots. I also found out my grandfather had it as well. So I'd been kind of kicking the can down the road, wanting to, I'll address it another time. I don't want to deal with it right now, etc. But in my 30s and 40s, I noticed it seemed to be getting worse. And what I ended up doing was I went to talk to my primary care physician, and he prescribed propranolol, a beta blocker, to me, which seemed to mitigate it to a degree. It wasn't a silver bullet, but it did help. And over time, I could tell that probably because of the stresses at work that I had to contend with, the effectiveness of the beta blockers seemed to kind of diminish. So he put me on primidone. I had a couple of incidents driving to work early in the morning after a nice restful sleep the night prior, where I would nearly fall asleep on the road. And that really spooked me enough so that I stopped cold turkey. I didn't even wait for doctor's supervision. I just let him know that, hey, I'd like to come in another time. Anyway, long story short, he agreed with the termination of that primidone, and he upped my propranolol. Time goes by, and I start noticing that the effectiveness of that propranolol, even though I was now on a higher dosage, was kind of limited. And it was a rather embarrassing situation, much like my predecessors had explained for themselves. We had instances of I'm in a very client-facing environment. I deal with Army personnel. I deal with the U.S. government buyers, and we're talking military aircraft. So you want to appear and sound as confident as you possibly can. And unfortunately, when you've got a tremor of this magnitude, which turned out to be bilateral, it affects not just head bobble, but also your voice. And it's it makes you very self-conscious, and especially when people try to say, "Hey, are you cold? Are you doing okay? I notice you're trembling and stuff." It's very hard to, I don't know, it's very hard to articulate to somebody who doesn't have a tremor of their own what it is you're going through. I mean, thankfully there's no pain, but it's still rather embarrassing. Add to that, when you're in a restaurant or a social setting or something as mundane as drinking water from a glass, eating soup, whatever, it's very difficult to, I mean, even sign your name having to do with both hands. And I began kind of exploring options, and I initially landed on uh, the focused MRI, and I discussed it with my wife, and there was no real committal there. I mean, I did inquire about it to a couple of universities and to see what the options were, what the costs were, side effects, things like that. And I talked to a neurologist here locally, and he was not even, this blew me away. He was not even aware of any remedies outside of medication for bilateral essential tremor. So I don't remember exactly how I got in touch with Dr. Halpern's team, but that's the route that I went. I reached out to them. They called me in for a discussion, a couple of discussions, and I remember talking to Dr. Halpern, and I asked the question, all right, if you had a sibling that you very much cared for that was my age, I'm 49 years old, that was in reasonable health and you know, had this stage of ET, what would you recommend they do? In other words, I was hinting for some guidance on whether it would be the DBS or the focused MRI, and he said, I, I'd recommend the DBS for you, and the reason is because at least for me anyway, he said that the side effects are, there's less a chance of side effects. You're young, you're healthy, your body can handle it. You can turn it off. In other words, in a certain sense, it's reversible because you can deactivate the machine. Um, and we went ahead with it. And I have to tell you, it, from the moment you complete that second surgery, although you're still having to fine tune the DBS system, um, it's life changing for somebody who's got tremor. And I knew full well that it was progressively getting worse, and it was not going to be getting easier unless I did something rather significant to deal with it. And their team, the professionalism, the effectiveness of what they did is just phenomenal. I can't speak to that enough. But I have encountered other people who have ET as well. Um, you know, I think anything from friends, coworkers to being at the chiropractor, whatever. And I'll see people who've got tremor themselves, and I advocate immediately that, hey, if you're inclined, I mean, give it a try. Just talk to people, see what your options are, and I do that for anybody else. I mean, here's my information. If you'd like to reach out, hang on just a second. Send this text. If you'd like to reach out, but no, I mean, there is some pain involved with it initially, certainly. It subsides, at least for me, it subsided rather quickly. I went through two surgeries. The first one to put the DBS probes in on my high forehead, and the second one was to put the power supply in. And the pain was pretty much completely subsided for both of them after about 6 days. Tylenol was my friend during that time period. Um, and the you know, swelling went down after about a month's time, and I wore bandages as well as hats when I had to go out in public. I was desperate to get out. I mean, considering what we had just gone through with COVID lockdown, I didn't want to be, you know, stuck indoors again for a month while my hair grows back. But you know, it's small price to pay from my standpoint. But right now, it's just I'm delighted with the turnout. I do agree with what the other individual said, that that you need to deactivate the unit overnight. You don't have to, but from what Dr. Hammer had explained to me, there is a um, I believe the term is elasticity, brain elasticity, or something to that effect, where your body actually acclimates to having the unit inside. And makes it a little bit more difficult. You're going to have to increase the settings over time, whereas if you deactivate it overnight, it mitigates that. You just first thing in the morning, you turn the thing on, you go brush your teeth or something. It's that simple. And the charger here, let me show you what the thing looks like. You hang this from your neck, and you just have the charging unit over the power supply, and it takes about 40 minutes to do, and I do that myself every 2 weeks. But that's about it. Are there any questions that I can help answer? All right. Thanks for your time, everybody.
Yeah, thank you so much for sharing your experience. I think it's been a great to hear about your perspective and how you were deciding between the two different treatment options and then having such a great outcome.
Pete, it's great to see you. Thanks for joining us.
You too. Thanks, Doc.
Dr. Talai, do we have any other patients joining us today? Patient advocates, patient ambassadors?
I think that's it as far as I'm aware, but if there's anybody else in the audience that I missed, feel free to speak up.
Well, Pete and Rob and Adrian, Bobby, Georgie, thank you all so much. And Dr. Talati, thank you for joining us as well and emceeing the patient perspective component of the agenda. I believe that we are coming to the end of our agenda today. Gabby, if you want to help field some additional questions, I might just bring up a couple of slides just to close things out here.
Yeah, it looks like there is, will this recording be available? Will there be a link to share with everyone or, oh, sorry, Andrea. So there will be a link. It's going to be sent out to all of the registrants in about 3 to 5 days.
Thank you, Gabby.
Anything else that was missed in here?
I tried to chime in as did Dr. Cajigas because sometimes it's we don't get to every question in the chat, but while he was talking and others, I was answering some questions, and I know he did the same, and Dr. Q. So if hopefully we addressed everybody's questions. I thought I would close with just a little perspective around deep brain stimulation and focused ultrasound. You know, we've touched on how these are elective procedures, and essential tremor is a benign condition. But, you know, it doesn't mean it's not extremely bothersome, by the way. And while these are elective procedures, it doesn't necessarily mean that you can put them off forever or that you'd want to put them off forever. In fact, you know, when I have patients that schedule the surgery, more often than not, they'd like to do it like in my next available as soon as possible. And, you know, usually I'm not available as soon as possible, which is one reason I'm proud to have been able to hire Dr. Cajigas and Dr. Q to join us at Penn. So we have a team and a service to help manage everybody's needs. But because these are considered elective procedures, I really think it's important for our patients' experiences to be, we need to learn from our hospitality experiences. When you go to a nice hotel, you have white glove service. And one reason I really emphasize the importance of this is because I really feel that the experience of the surgery, everything leading up to the surgery and what follows, can make or break the overall experience. And if you have malignant cancer or something like that, we try to strive for that kind of service as well, but it might not be as necessary. The patients that spoke up on our behalf today and on behalf of the therapy, I think benefited both from what this amazing therapy does, but also from sort of the culture of our shared clinics, which is sort of a white glove service. And if we don't achieve this, well, we certainly strive to, because I want the access to be easy. I want the process to be streamlined. Meanwhile, we'll keep you safe and get you a great outcome. These are the team, the speakers from today, and I'd like to thank Gabby for being the MC, and for Dr. Talati for helping work with our patients this afternoon. Dr. Cajigas and Dr. Q for being the best partners a partner can have. I can tell you that a lot of people who meet Denise, who is my nurse practitioner, sometimes they say things like, I really enjoyed meeting your assistant earlier, Dr. Halpern. And I have to remind patients that she's not my assistant. If anything, I'm her assistant. I work for Denise. She's our fabulous nurse practitioner, an amazing clinician. And we're very privileged to have her help take care of our patients. And she leads a team of nurse practitioners, including Jamie Pissarro, who works a lot with Dr. Cajigas as well. Dr. Feldman, thank you so much for joining us as well. She's a wonderful collaborator of ours at Penn. She sees patients in Bucks County, at Chalfont and Sellersville. I have her contact information if you ever need to reach her. We have dozens of patients together, both with focused ultrasound and deep brain stimulation, that have tremor. And our patients' experiences in terms of white glove service extend to her clinic as well. Jennifer has also become a wonderful friend and colleague. She is the founder and CEO of Dynamic Home Therapy, not just a doctor of physical therapy, and a great person. And her team of tremor experts who are also physical and occupational therapists can be vital partners in taking care of patients. So we're very thrilled to have partners across disciplines because the surgical team can't do everything by itself. These are the locations where you can see us. Jennifer's group is, they have their Rocksteady Boxing clinic in Berwyn, but they do home physical therapy. Dr. Feldman's in Bucks County. But from a surgical standpoint, if you ever need to talk to us about these procedures, we come to you as much as we can. We are certainly at Pennsylvania Hospital, America's First Hospital. We also see patients in the neurology clinic at Penn to provide a multidisciplinary experience when necessary. Denise and I go to Cherry Hill. We were there yesterday, as well as Princeton, New Jersey. We have a lot of patients in the Northern Jersey, New York area that see us there. And then my partner, Li-Ming Q, sees patients at the Radnor Clinic. My partner, Iahn Cajigas, I have to credit him. He drives the furthest. He goes to Lancaster General Hospital and has a multidisciplinary clinic there with their neurology group, also part of Penn. If you ever need to reach us, there's an email here that Gabby helps manage, and we will always get back to you as quickly as we can. If you don't hear from us, email us again, and always try the phone number 215-829-6700. Gabby, any additional information we should share before we close for the day?
I don't think so. I'm trying to think if there's any other contact. I think that would be, you covered it all.
How about the Boston Scientific team? Matthew, Jamie, Ashley, and Joshua are partners in your care. They don't represent the focused ultrasound experience, by the way. That is the InsightTech team, but they do represent our fabulous deep brain stimulation partners. They'll be present for your surgery, for your follow-up clinic appointments. They've been integral in the success of all of the patients we've taken care of and continue to do so. They make themselves available to you 24/7 as well. So thank you to them for helping take care of our patients and doing a great job, and also for organizing this webinar, which I think has been a great success and a fabulous educational event.